Can you hear me, Dr. Jayavinda?
Yes, sir. We can hear you and we can see you also.
Oh,
Good
but
evening, sir.
picture is not appearing here.
We can see you, sir.
Okay, before we start, I just have a suggestion and a request.
Yes, sir.
In our group, I think we should not have any religious messages.
Okay, okay. I will take care.
Available to everybody.
Okay, okay, sir.
Okay, let's purely have it as
We are
a
good to go.
Yeah.
comment.
Yes, I will keep in mind, sir.
Oh,
Okay. Good evening, everyone, and welcome to the another exciting and knowledgeful session of pediatric endocrinology for the postgraduate. So this is a special program dedicated to postgraduates, and we discuss exam-oriented cases, specially directed toward the PG and DNB students. So we will begin the first PEP session for this year. And I will request now Dr. Anurag Bajpayee, President ISPAE, to say some words, followed by Professor Raghupati, who has coined this program, and this is his brainchild. So, sir will share his vision regarding this program. Thank you. Anurag, sir, please go ahead.
Thanks a lot, Dr. Jayavinder, and warm welcome to everybody, and pranam to Professor Raghupati. This is one of our inaugural program as far as the new ISPAE executive is concerned. And this, in fact, is an initiative which has been there for quite some time, a brainchild of Professor Raghupati. And we are really honored to have this session going on as part of the ISPAE program. We all know that the most important aspect as far as pediatric endocrinology is concerned are focused about general pediatrics, and every pediatrician should be aware about that. The aim of this program is to inculcate the information and knowledge about pediatric endocrinology across postgraduates at an early stage so that we can have a good formative establishment as far as the knowledge is concerned. The theme for today is also extremely important of both congenital and acquired hypothyroidism. Despite so many advances and so many initiatives which have been taken, there is lack of awareness, delayed diagnosis of both congenital and acquired hypothyroidism with disastrous consequences. And we hope that this program will go a long way in enhancing the awareness on that. At the very offset, I'd like to thank Professor Raghupati and Dr. Amarnath, who has been involved with this program for a long time, Dr. Jayavinder and Dr. Vijay Jaiswal, who has been doing a lot of hard work in conducting this program. Professor Anna Simon and Professor Vandana Jan, who have volunteered to spare their valuable time to dwell about these topics, Dr. Ayesha and Dr. Anjali, who will be covering as far as the case mentee the concern, and I'm sure this is going to be an academic feast. And we at ISPAE conduct a number of programs, including the pediatric endocrinology for postgraduate program, which is this one. We have a pediatric endocrinology for practicing pediatrician, which happens once every 3 months, and a special program for pediatric endocrinologists. So I'll request all of you to join in other programs, and I'll encourage all the postgraduates to join ISPAE as a society. Once again, thanks, Dr. Jayavinder, for the invite.
Thank you, sir. Raghupati, sir, for your wisdom words.
good evening, my dear colleagues and friendly postgraduates who are the main audience for this program today. And I must have said this earlier in programs like this, but I would like to say for the people who are joining new, that at one time I saw out of 40 questions in the DNB question paper, 14 happened to be in pediatric endocrinology. And that really shocked me, though I was happy pediatric endocrinology questions were there, but I felt very sorry for postgraduates in institutions where there is no teaching. And you all know, even in medical colleges, there is no pediatric endocrinology being taught. And that's why this was started. Initially, it was on a small scale, once in 2 years and all. But after that, it's been going on. Thanks to COVID, we made it more frequent and also more online. Earlier, it was all in person, and we had to restrict the numbers because we wanted it to be a workshop. And I'm grateful to Dr. Anurag also, who has participated in these programs, and he has come all the way to Coimbatore and all to teach the postgraduates. And I'm very grateful to Amarnath, who has been continuing after one session which we held in Hyderabad. After that, as an executive member, he has been doing it for a long time with a sustained interest. And I'm really grateful to him. And I'm also grateful to the current executive committee who has taken up this challenge. And I'm glad to see the interest that Dr. Jaiswal and Dr. Jaivinder have put in. And I do wish you very good luck, and we'll hope to keep the endocrinologists, the budding pediatric endocrinologists, with a lot of interest in the subject. And the idea is also to convert them, you know, to this subject, an interesting subject. Once they get into our fold, they find it very effective, and many of them have opted to do pediatric endocrinology. And with these words, I wish the program continued success in the future. Thank you.
Thank you, sir, for your kind words. So we will begin the program now. So the first case will be presented by Dr. Tushar Khetan. So he is 5th semester MD student from PGIMR Chandigarh. He will be presenting a case on congenital hypothyroidism. And the examiner for the first case is Professor Anna Simmons. Ma'am is senior consultant and professor, Unit 1 Pediatrics at CMC Vellore. So ma'am is well-known pediatric endocrinologist, and she is an excellent teacher, written various chapters in multiple books, and she has multiple publications on her name. So over to Tushar and Anna ma'am. So Tushar will be presenting case with discussion, followed by lecture by Professor Anna Semen on congenital hypothyroidism.
Just before Tushar starts, can I have a word, please?
Yes,
So,
please.
of course, there is definite limitation of presenting a case with just slides than bedside clinical examination. So, can I interrupt Tushar in between if I have some comments?
Yeah. Yes, ma'am, you are free to interrupt and ask. Yeah.
Thank you.
Tushar, you can share your slides and start.
Yes, good evening, everyone. I'll share my slides. Uh, Can
Yes. Tushar, your slides are not visible. Make them in, now they are visible. Make them in
Okay.
slides.
Okay.
Yeah, now they are visible.
Good evening, everyone. I'm Dr. Tushar. I'm a third-year MD Pediatrics resident from PGI Chandigarh, and I'll be presenting the first case for the day. Our index case is baby A, 4-month-old girl from Jalandhar, Punjab, was admitted with us on 27th of August 2020 for a total duration of 3 days. She presented with chief complaints of excessive irritability, poor weight gain, and constipation since 2.5 months of life. Coming to history of present illness, antenatal wise, the child was first born to a non-consanguineously married couple. They had history of 1 first trimester abortion previously, with no history of any thyroid illness in family members. Antenatal period was otherwise uneventful. Coming to birth history, the baby was born at full term by LSCS in view of meconium stained liquor with birth weight of 3.2 kilos. The baby cried immediately after birth and was discharged on day 4 of life. Mother subsequently noticed that since day 7 of life, the child was continuing to have persistent mild jaundice until 1 month of life, but it did not require any active intervention for the same and was told to be normal by the local hospital. The child was otherwise accepting breastfeeds well. The child remained apparently well till 2 months of age. Subsequently, the mother noticed that the child became progressively irritable, initially in the form of increased cry and later associated with decreased feed acceptance and decreased consolability. Also, the mother noticed that the child was having poor weight gain and it was associated with decreased feeding, along with constipation, which with the frequency of passing stools once in 15 days with hard consistency. This was otherwise not associated with blood in stools, but it was associated with excessive crying, and it was relieved with intermittent use of suppositories. Ma'am, this thing is mute. Can't hear you.
So I just wanted to interrupt here
Yes,
because your presenting illness is excessive irritability, isn't it?
yes, ma'am.
From
Yes,
about
ma'am.
2.5 months of age.
Yes,
But
ma'am.
I know you know that this is a case of hypothyroidism. Irritability is not a character of hypothyroidism. Hypothyroid babies are usually they very poor cry, they have
Yes, ma'am.
somnolence, they sleep excessively. So can you give us a little more details about that excessive irritability? Like, could you find why this child was irritable? Like what time of the day? Was it before feeds? Was it when the child was hungry? Was it an evening colic? Or was it a G reflex causing heartburn? What did you think that irritable cry was? Was there anything like crying while micturition, crying while passing stools? Was there anything to suggest a cerebral irritability? Because that's a very unusual finding for a hypothyroid baby.
Yes, ma'am. This excessive irritability was most likely seen in the form of evening colic, because otherwise the child was passing urine well, did not cry while passing urine. Feeding was also okay. Otherwise, also there was no signs of cerebral irritability otherwise, because the child seemed to be active, not so lethargic all the time. So maybe it was part of the colic, which was secondary to constipation. That is what I considered in this case, ma'am.
Okay, carry on.
Yes, ma'am. So the child also had constipation, passing stools once in 15 days with hard consistency and not associated with blood. There was otherwise no history of fever, no history of cough or rapid breathing. There was no history of suck rest, suck cycle, forehead sweating, or cyanosis. Child also did not have any associated crying while micturition, vomiting, or abdominal distension. No history of lethargy, altered sensorium, or seizures, or no history of any early neonatal or infant deaths in the family.
I would also like to comment here that you said apparently well till 2.5 months, but at the same time, you said that the mother noticed that the baby had jaundice from day 7. Jaundice
Yes, ma'am.
starting at day 7, probably you can't call it apparently well. There has
Okay,
been
ma'am.
some process there where from day 7, there has been some illness noticed. Just
Okay,
like
ma'am.
that out. Yes.
Okay. So for these above mentioned complaints, the child was taken to various local hospitals nearby and was showed multiple times. Initially, the child was told to be normal, but later was evaluated at 3.5 months of age at a private hospital in Jalandhar and was referred to PGI in view of abnormal reports. Coming to developmental history, the child had not attained neck holding and the child had no social smile at 4 months of age. So definite developmental delay was there. Immunization wise, the child was immunized up till age. On general examination, the child was vitally stable. Anthropometry wise, the child was severely underweight with a weight of 3.8 kilos, standing at minus 4.08 Z scores, and a small head with head circumference of 38 centimeters with minus 2.05 Z scores. Coming to head to toe examination, the child was noted to have open anterior fontanelle with open posterior fontanelle 0.5 into 0.5 centimeters. The child also had a sallow appearance with hoarse cry, dry skin, excessive scalp hair, macroglossia, along with protuberant abdomen and umbilical hernia. Coming to systemic examination, the child was noted to have hypotonia of all the 4 limbs with normal power and all the reflexes were present. Cardiovascular system examination was within normal limits. Per abdomen examination revealed a protuberant abdomen. However, the abdomen was soft and no organomegaly was noted. The genitals were normal. Respiratory system examination was unremarkable. So in database, we have a 4-month-old girl who presented with complaints of excessive irritability, poor weight gain, and constipation, along with developmental delay and a history of prolonged neonatal jaundice. On examination, was noted to have failure to thrive with small head and features suggestive of hypothyroidism. Subsequently, the records reviewed showed that the child had raised TSH levels. So initial diagnosis considered was congenital hypothyroidism, likely secondary to thyroid dysgenesis or agenesis versus dysharmonogenesis.
So would you please be able to just tell us in that history, what were the markers towards hypothyroidism?
Okay, I'll show that slide right now.
No, it's
So,
there in this current slide itself. Those are the systemic examination. But in history, what made you suspect that there could be congenital hypothyroidism? It is there in
in
the
the
slide. Yes.
okay, ma'am, in the history, we'll say at the onset, prolonged neonatal jaundice
Yes.
was a
Very good.
pointer
Prolonged
towards,
neonatal jaundice.
yes, ma'am. Along with that, poor weight gain, constipation, and developmental delay is also a
Okay,
pointer
good.
towards congenital hypothyroidism.
Okay, good.
Along with that, ma'am, on examination, failure to thrive was there. However, small head is not a feature, not commonly a feature of hypothyroidism. It commonly presents with near normal or slightly increased head size.
That is right.
And along with that, features of hypothyroidism were found on head-to-toe examination, which included excessive scalp hair along with a protuberant abdomen and umbilical hernia, along with open posterior fontanelle even at 4 months of age.
Yes, agreed.
So, man, the previous records revealed a raised TSH level, so possibility of congenital hypothyroidism was considered, and it was etiology considered were thyroid dysgenesis and versus dysharmonogenesis. I'll continue, ma'am.
Yes, please.
So, base.
Here, Anna.
Uh,
Anna,
yes,
Yes,
yes.
sir.
with your permission, can I ask one question?
Yes, please, sir.
Also, newborn screening done?
No. This is a presentation at 4 months of age.
No, but we just want to know whether newborn screening was done, and just wanted to stress the importance of newborn screening, and then this child would not have been delayed for diagnosis so long. Were they seeing a pediatrician also for all these complaints?
Yes, sir.
Because the pediatrician should have picked up prolonged neonatal jaundice, constipation, and it's a good call for all the pediatricians to be aware of this. Okay. And was there any relief after passing of stools? Did the child stop crying? Irritability, did it improve?
So there was a slight improvement in the irritability. However, there was baseline irritability persistent throughout. Some relief was noted intermittently with passage of stools.
Especially if the child was born in a private setting, if newborn screening is not done, that's a very, very criminal thing, I must say. Okay, carry on, please.
Okay, sir. Baseline investigations done at our hospital showed mild anemia with a hemoglobin of 10.7, along with slightly elevated MCV at 89. Metabolic parameters sent showed transaminitis with AST of 1100 and ALT of 520 with normal ALP.
So can you just
Dr. Tushar, excuse me, ma'am.
go back to that? Go
Yes,
back
ma'am.
to that. Yes, Dr. Aisha, you were saying something?
Yeah, Tushar. Yeah, I just
Yes, ma'am.
wanted you to throw a bit more light on developmental delay that you were talking about. Can you go back to the slide? If I'm allowed, Anna ma'am, with your permission.
Yes, but yeah.
So about the
Yes, ma'am.
developmental delay, so you just talked about one domain of developmental assessment, about
Yes,
the
ma'am.
gross. So
Yes, ma'am. Neck holding and no social smile was there actually, social
I
and
would
gross.
suggest even you should include the whole developmental examination as a part of your examination, and also the
Okay, ma'am.
hearing and vision assessment as well. Because
Okay,
there is developmental delays, all the maneuvers like pull to sit, all those should be included as a part of your examination.
okay.
Okay, and how do you explain that excessive hair you were talking about? So what is the reason behind that? Because you said no,
This,
excessive hair on the head. So any significance associated with the condition that the baby has?
mm, it's it, it's been a noted finding in congenital hypothyroidism that these children have brittle hair which appears with a low hairline. Exact cause as to why it is found, I'm not aware, ma'am.
Is it a part of any syndrome or with any kind of congenital
I
hypothyroidism?
also don't think it's
Yeah.
excessive hair detail.
Excessive hair, yeah, never heard of that. Yeah.
Sparse and brittle hair.
Gee. So I would
Okay.
suggest that developmental examination should also have been included, right?
Okay.
And hearing assessment as well, because this could be a part of any syndrome, this congenital
Okay.
hypothyroidism. So otherwise, that's fine. Go ahead. Thank you. Thank you so much.
Okay.
So coming to your investigation slide, the first investigations,
Yes,
can
ma'am.
you
Yes, ma'am.
explain what is your inference in there? Anything to support this diagnosis? What all are you seeing? You're seeing a mild anemia.
Yes, ma'am. And the macrocytic picture is seen,
No, I
ma'am.
think 89 is okay for that age group. In the lower age group in infancy, the MCV is slightly higher than adult values.
Okay.
So that may be a normochromic, normocytic anemia. But can hypothyroidism explain that?
Uh,
Yes,
Mac.
anemia is one of the common manifestations
Yes, ma'am.
of hypothyroid. And then coming down to your electrolytes, what is your comment on
Hyponet.
electrolytes?
Hyponatremia is that's part of hypothyroidism, ma'am.
Why do they have hyponatremia in hypothyroidism? So that's because thyroxine is required for the free water excretion. So when you're hypothyroid, the free water excretion is inhibited, and then you'll get a dilutional hyponatremia. What would you say about the urea and creat? Do you think that is okay for that age group?
The first value seems to have slightly elevated urea, but
Yeah, they are
subsequent values were normal. So
the creat is also slightly elevated for what was the weight of this child?
this child was around 4
We're
kilos, ma'am,
failing to
around.
try. So the
Yes,
creat
ma'am.
is also slightly higher, and you can have hypothyroidism affecting renal functions also. It's very well known.
Okay, ma'am.
Start treating, the creatinine keeps improving. And what about what are the next findings? What about the
Transaminitis.
transaminases?
Yes, ma'am. This hypothyroidism has been shown to have relation with transaminitis, but it's generally around 2 to 3 times upper limit of normal. If still higher values are there, we can also think of some other cause.
Yeah.
But still, it has been found association, and cause is mostly secondary to cholestasis, which can lead to hepatocyte dysfunction.
Yes, but cholestasis, your ALP is completely normal.
Yes, ma'am.
So there is no cholestasis, but there is a elevation of the transaminases.
And
Especially the AST. Probably some may be also from muscle origin because they
yes, ma'am.
have some myopathies.
Myopathy, yes, ma'am.
Right? Yes, go on. Go on to the next slide.
Yes. So specific investigations done showed highly elevated TSH at 100 microunits per ml with low T4 at 0.42 microgram per deciliter and T3 of 0.15 nanogram per ml. Ultrasound thyroid.
Before you proceed further, I would like to make this comment that ideally for hypothyroidism, in the diagnosis of hypothyroidism, T3 does not have any
Yes, ma'am.
importance. T3 is probably important when you're looking at hyperthyroid cases. But what is missing here is a free T4. Of course, the total T4 is low. That can be erroneously low with some other conditions. But what is missing here is a free T4. So whenever you want to say hypothyroidism, it's probably good to have a TSH value and a free T4 essentially, and a total T4 if you can do it. T3 probably is not required.
Okay.
So here we are missing a free T4.
Okay. And ultrasound thyroid was subsequently done, which showed.
T4 is done.
Yes, sir.
I'm saying that in our institute, ma'am, T4, total T4 and TSS are being done inside. Free T4 is not available.
Yeah, because the problem is the total T4 can change depending on the TBG values. So if the thyroid binding globulin are different, you may get a total T4 which is also different. I will come to in my lecture slides. I'll just give an example. So worldwide, I think the consensus is that we should have a free T4. Free T4 values are very difficult to interpret, and even each lab, the accuracy may be very different also. You have to be a little careful about interpreting free T4 values, but that is the test to be done when you're looking at hypothyroidism. And T3 doesn't play much role actually.
Yes, yes.
Yeah, go on.
Yes, ma'am. So ultrasound thyroid was done, which showed bilateral lobes of thyroid were not visualized, likely atrophic or absent. Ultrasound KUB was also done, which showed normal kidney size with mild splitting of the pelvic ileal system. Echo screening was done, which showed a ostium secundum ASD with left to right shunting, standing at 5 mm size. So final diagnosis kept was congenital primary permanent hypothyroidism with thyroid dysgenesis as the etiology, with underlying ASD of 5 mm size with splitting of the pelvic ileal system. Likely genetic cause considered was NKX 2.5 mutation versus PAX8 mutation.
So when you say thyroid dysgenesis, what were you thinking of? Any one of the thyroid dysgenesis?
Since it was absent, most likely it is agenesis.
But you
However,
cannot rule out
yes,
ectopic
yes,
thyroid ultrasound.
that scintigraphy scan is required to completely rule out ectopic
So
thyroid.
an ectopic thyroid cannot be ruled out, but a hypoplastic thyroid in situ or a hemiagenesis
Yes,
all can be picked up by an ultrasound. Ectopic thyroids cannot be picked up by an ultrasound.
yes, ma'am. And also, ma'am, this thyroid congenital hypothyroidism is commonly associated with other anomalies in 10% cases, and out of that, cardiac anomaly is most common. So that might explain this underlying.
That's also not a correct statement. It's not commonly, can be associated.
Okay.
Commonly, they are just congenital hypothyroidism, only thyroid pathology. Less commonly, they can be associated with other system malformations, and you have all the genetics for that.
Okay. The child was subsequently started on tablet levothyroxine at 10 microgram per kg per day. A repeat TFT was done after 4 weeks, which showed a normal TSH value of 3.8 micro international units per ml and a free T4 of 0.88 nanogram per deciliter. So the child was subsequently continued on the same dose of levothyroxine, and repeat TFT was advised after 2 months.
So here again, I have some comments. I'm very glad that you repeated after 4 weeks and then you're planning to repeat after 2 months because the constant follow-up is necessary. But here, if you depending on how low the thyroid is, hypothyroidism is, the degree of you can choose from 10 micrograms to 15 micrograms per kg per day. And all consensus statements, whether it's European Society or American Academy of Pediatrics or even our ISPAE guidelines, would suggest that when you give the thyroxine dose, we are expecting the free T4 to be in the upper range of the reference range for that age.
Okay.
It's very important that we use age-appropriate values. According to ISPAE guidelines, the free T4 at 4 months, 3 to 9 months or something is like 1.1 to 2.4, and in the European society it is 1.6 to 2.8. So the free T4 is slightly higher in infancy than in adults. So I think the aim of continuing the same dose probably was not right. The child probably needed a dosage revision with increasing the dose of thyroxine to bring the free T4 in the upper half of the reference range for that age.
Okay. So child was subsequently planned for hearing evaluation and growth monitoring in follow-up. Repeat echo along with ultrasound, kidney and genetic testing was advised during follow-up. So
why do you think
these
of
are,
hearing evaluation separately? Hearing evaluation, what came to your mind when you were asking for hearing evaluation?
in cases of dyshormonogenesis, Pendred syndrome can be
Pendred
associated
syndrome.
with sensory
Pendred
neural
syndrome,
hearing.
yes.
Yes, ma'am. So these are my take-home messages. Congenital hypothyroidism should be suspected in any newborn with prolonged jaundice, and it is the most common cause of preventable intellectual disability. Out of these, thyroid dysgenesis is the commonest cause for congenital hypothyroidism, and primary TSH-based screening is recommended. Also, imaging should never be the reason for delay in initiation of therapy. The child should be started on levothyroxine based on TSH values during screening, and then imaging can be done to look for the etiology. Early and adequate treatment is the key to prevent neurological damage. Thank you.
Will you keep any other differential diagnosis of any child who is failure to thrive, constipation?
Yes, sir. If the child has constipation during the infantile age group, we'll primarily, first of all, consider functional causes. However, if there is associated failure to thrive, organic causes should be considered. Out of that, gastrointestinal causes can be considered in which Hirschsprung disease is one of the common causes. Also, other causes can include endocrine causes. One of them is congenital hypothyroidism. It can also be associated with hypercalcemia. Other causes can include neurological causes, which include cerebral palsy, or genetic causes can also be considered, which include Down syndrome.
What was the feeding history of the child?
The child was directly breastfed.
Okay. Because that may be related to the excessive irritability and small head size.
So, and Tushar, any rationale behind repeating the genetic testing, as you had said?
Ma'am, only genetic testing was not done previously, ma'am. We had considered the possibility.
Okay, but you told that. Okay, so that was after, in the follow-up, you got that done.
Yes, ma'am. Yes,
Obviously.
yes.
Okay, okay. And so did you talk about the type of the differential of the bilirubin, the type of bilirubin, whether it was direct or indirect? I missed that part, perhaps.
No, ma'am. Actually, only history of prolonged neonatal jaundice was there, but we did not have records of the same.
Okay, okay.
Yes,
Or not at 4 months, you did not find any evidence of
no, ma'am. No,
cholestasis.
no, ma'am.
Okay.
ALP was also normal, and transaminitis was
Enzymes
there.
were elevated,
You
you
don't
said.
have a
Yes.
bilirubin level in that test. Did you have a bilirubin level recorded?
No, he didn't.
No, ma'am, we didn't have it here. It's not there in this, but we had done it. It was normal.
Ma'am, should we stop here? Anybody else wants to ask any questions regarding first case? Otherwise, we will proceed for ma'am's lecture.
I think we should proceed for ma'am's lecture because he has already told and ma'am has cross-checked. So let us listen, ma'am.
Okay, okay. Thank you, Dr. Vijay.
So I'm just trying to share my screen. So is that visible?
Yeah, they are perfectly.
Slide visible?
Yes,
So
yes.
let's go through this. I mean, I'm just starting to say that hypothyroidism is a very common disorder in children. Though it is similar to adults, there is a lot of difference between the incidence, the presentation, and the clinical consequences. So as pediatricians, we need to be aware of this. And the first thing is, as said often, and it has been also said during this case presentation, failure to diagnose congenital hypothyroidism and treat it promptly and adequately can lead to irreversible neurocognitive sequelae. So that is the greatest message here in the first when we start. I'll just take you through this hypothalamus pituitary thyroid axis. Since with the postgraduates, a recollection of the primary physiology. We all know that the hypothalamus produces TRH, which acts on the pituitary to secrete TSH, and then TSH acts on the thyroid gland, and then thyroid hormones are released. So thyroid hormone, both T4 and T3, have a negative effect on the center, especially the anterior pituitary, and indirectly on the hypothalamus as well. So we have 3 levels of dysfunction of thyroid disturbance. It's called primary hypothyroidism, when the thyroid gland is not functioning. And it is secondary hypothyroidism if there is a defect in TSH secretion, and tertiary hypothyroidism if TRH is affected. Tertiary and secondary hypothyroidism together is called central hypothyroidism. It's probably better labeled that way. And we have primary hypothyroidism, which is the most common than the central hypothyroidism. And also quickly running through the actions of thyroid hormones, metabolic effects which happen in all age groups. The most important thing is thyroxine increases the basal metabolic rate. It is there with thermogenesis. It increases glucose metabolism by increasing gluconeogenesis, glycogenolysis, and insulin-stimulated glucose uptake is also increased. It causes lipolysis and fatty acid oxidation, and also stimulation of adrenergic receptor binding. The other actions which are very important in early childhood is CNS development and function. Though we all know that hypothyroidism, we keep looking for MRIs where myelin is delayed, myelin formation is delayed. So thyroxine is very essential for myelin formation. It also stimulates neuronal cell maturation and migration. It stimulates the dendritic branching and synaptic formation, and also influences neurotransmitters, enzymes, and cell proteins. That is why if hypothyroidism is not adequately treated in early neonatal period and early infancy, you end up with irreversible neurocognitive sequelae. And with growth and development also, thyroid has a great effect, direct effect on growth. It stimulates pituitary growth hormone synthesis and secretion, IGF synthesis and action, and including protein synthesis. You can see everything required for growth is also affected by the thyroid hormones, and it also enhances IGF-1 action on the bone and cartilage. Now, this is a slide to show the steps in thyroid hormone synthesis in the thyroid gland. I just put it up because all of you are well aware. You have learned it through your physiology classes. Iodine is first taken up by the sodium iodide symporter into the cells, and then through the Pendrit channel, it is pushed into the colloid, where with the action of TPO, the tyrosine molecules of the thyroglobulin are iodinated to monoiodotyrosine and diiodotyrosine, and then coupling occurs with the deox-2 and deox-A2 enzymes to form thyroxine. Then this thyroxine, the thyroglobulin molecule, is by endocytosis taken into the cell, and by lysosomal degradation, the thyroid hormones are released into the bloodstream. And after the usage, the recycling of iodine released by dehalogenases are further again used for thyroid synthesis. These steps are very important because that you can see that any one of these steps are affected, then it causes thyroid dysharmonogenesis and hypothyroidism. So this is a picture which I wanted to show you. This is a boy we saw in our OPD at 11 years of age. Somebody brought him from the village. And you can see that this is an undetected congenital hypothyroidism, ectopia. And you can see how short he is. He's got all that hypothyroid creatine phases, and he's sort of even disproportionate. And you can see the very dry skin. His height age was something around 4 years of age, and he was severely affected because this was not detected earlier. So how do we make a diagnosis of hypothyroidism? We need to do TSH, free T4, and if possible, a total T4. Primary hypothyroidism is characterized by a high TSH. The third generation TSH assays are so sensitive that even before the total T4 or free T4 lowers, the first thing to appear is an elevated TSH. So that's a very sensitive marker, elevated TSH, and then for frank hypothyroidism, you will get low T4 and low free T4 as well. In the case of central hypothyroidism, the TSH will not be elevated. You will get low to normal TSH with a low T4 and a low free T4. And as Dr. Raghupati rightly pointed out, congenital hypothyroidism should be diagnosed by neonatal thyroid screening for reasons which I will shortly come to. So we make a diagnosis by doing elevated TSH, low T4, low free T4, and then as rightly done in that case presentation, is followed by an ultrasound thyroid scan. Nuclear scan, technetium 99 or I-31 can be done. Technetium 99 is more safer. Actually, in Western countries, where there are good ultrasonologists who can do good neonatal thyroid scans, they are giving off the nuclear scans because of the cause of the radiation which is happening and the expenses also. So ultrasound thyroid scan is good. The only drawback is an ectopic thyroid cannot be diagnosed readily with an ultrasound thyroid. A perchlorate discharge test may or may not be done. That depends on if you want to get a definite diagnosis. Now, the clinical manifestations of congenital hypothyroidism, as said here, most of the time they are asymptomatic at birth. Remember that thyroxine T4 can be passed on from the placenta into the baby. So the babies are asymptomatic at birth, and they slowly start manifesting it after a few days. And the next most important symptom that pediatricians should be aware of is prolonged physiological jaundice for many reasons, because the liver enzymes, the maturity requires thyroid hormone, and so they go into a prolonged physiological jaundice. These are the two important features which pediatricians should be aware of: asymptomatic at birth and the prolonged physiological jaundice. What are the other sort of symptoms that will be there with most of the babies is somnolence, that is sleeping excessively. They'll be very sluggish. They'll have a very poor cry. They're supposed to be no trouble babies. They will be always sleeping. They will feed less. Hypothermia may be recorded. They are hypotonic, and usually they'll also have a mild bradycardia. By the time the bigger features like a large tongue, hoarse voice, mild microcephaly, because the bones are not maturing well and the AFs are all open, umbilical hernia, edema of the genitals and extremities, dry skin, coarse hair, you're already severely hypothyroid. But watch, as a pediatrician, the nursery, we look for excessive sleeping, low heart rate, prolonged physiological jaundice, hypotonia. There should be a high index of suspicion. So the clinical manifestations are very difficult to diagnose them early. That is why neonatal thyroid screening is very important. So this is a classical picture of an untreated congenital hypothyroidism, which you all have seen. And here you can see, a very shallow complexion, slightly looking yellowish, a large macroglossia, and hypotonia. The posture says there is hypotonia. There's a protrudent abdomen because of muscle hypotonia and an umbilical hernia. You can see this is the classical features of an untreated congenital hypothyroidism, which I hope in the future we don't get to see, where neonatal screening will help us to diagnose them early, and we can all treat them early without having any neurocognitive sequelae. So thyroid causes of congenital thyroid are broadly divided into thyroid dysgenesis and thyroid dysharmonogenesis, as rightly pointed out by Tushar. So if you do an ultrasound, nuclear scan, thyroglobulin levels, true agenesis will have thyroglobulin levels which are undetected. So if you do an ultrasound and if you have no thyroid tissue seen in the thyroid bed, and then you have some thyroglobulin which is detected, you may suspect that there is a ectopic thyroid. So ultrasound and thyroglobulin levels together may take the need of a nuclear scan to detect an ectopic tissue, because you can get thyroglobulin levels detected and no thyroid tissue seen by ultrasound in the thyroid bed. A hypoplastic gland in situ also can be picked up by a thyroid ultrasound, and they may not be need of a nuclear scan. And hemiagenesis thyroid is the other common thyroid dysgenesis, which is seen where you have aplasia or hypoplasia of one half of the thyroid gland with the isthmus or without the isthmus. There is one entity called apparent athyrosis, where we will tell you that is a term which has come when we do a nuclear scan, there is no uptake, and so it is mistaken for a thyroid agenesis or an true athyrosis. But you can see that thyroglobulin levels are detectable, and later if you do an ultrasound, you will find a normal thyroid gland. For many other reasons, we'll come to that. So when we talked about the steps in thyroid hormone synthesis, that each step can be affected so that you get dishormonogenesis. Starting from the iodide trapping to the iodide efflux into the lumen, then the matrix hormone synthesis, thyroglobulin, and then the organification and coupling, and then the so all these things, any one of them, if they are affected, you will get a dishormonogenesis. Usually in a dishormonogenesis, the thyroid gland will be slightly enlarged, or it can be even of normal size. So if you have an ultrasound showing a normal size or a larger than normal size with hypothyroidism, you would think of a dishormonogenesis. And all these genes have been mapped, and we can make a good diagnosis with all of them. So the pendrin gene is where you are also affected with sensory neural deafness and enlarged vestibular aqueduct there, and you'll also have a goiter. Most of the dishormonogenesis can present with a goiter. Sometimes the goiter can be so large that it may cause obstructed second stage of delivery also. So there, when we talked about thyroid dysgenesis, as Tushar had mentioned, these are the currently known gene defects for thyroid dysgenesis, and you can see that the thyroid phenotype is mentioned here, starting from the TSH receptor gene to multiple other genes which are here. You had suspected NKX25 or PAX8, but of course there is this JAG1 where you have thyroid hypoplasia and heart defects, whereas in NKX25 gland is always in place, is what they have said here. This is from the recent pediatric in 2022, published by ISPAE, actually, the European Society of Pediatric Endocrinology. So, I mean, this is just for your information that sometimes thyroid dysgenesis may be associated with other anomalies, and there may be an underlying genetic defect, which may help us to counsel the parents and also to prognosticate about the disease. So then comes the main important statement where Dr. Raghupati sir has just said that we have to screen for congenital hypothyroidism. Why? Because clinically detecting congenital hypothyroidism is very difficult. You need a very high index of suspicion because the symptoms and the signs are so subtle. And early diagnosis and early treatment can prevent the consequences. So we don't want to wait till the clinical manifestations are present to diagnose congenital hypothyroidism. So screening is a very essential tool, I think, in this age. And congenital hypothyroidism will satisfy all the criteria for a biochemical screening. So why do we need a screening? One is, as said before, late diagnosis leads to negative and undesirable outcomes. And it's a difficult clinical diagnosis. So we have this biochemical tests which are so good, and the accuracy and reproducibility of these third generation TSH assays and free T4 are so good. And once you diagnose, there is the effective intervention is available. That's also very important. It's not just diagnosis and we have nothing to do. We have an effective intervention which is easily available and cost effective. So the learning points here is we have to screen all patients, all babies inborn universally should be screened for congenital hypothyroidism. But the time for screening is very important. We in CMC do a cord blood, but probably a cord blood has a bigger recall rate, or you should do a screening after 48 hours with heel prick method. The first 24 hours is the maximum fluctuation of TSH occurs because of the physiologically itself, the stress of birth and the baby entering from a warm uterine environment to the exterior world. There are a lot of fluctuations in TSH levels, so it's ideally not collected within the first 24 hours. But always remember, screening is not a diagnosis. Repeating the blood test, including a free T4, you should be done to confirm the hypothyroidism. And always we have to use age-appropriate values for interpreting the TSH and the free T4 levels. That is very important because most of the time we will see mismanaged patients because age-appropriate values are not used. So I'll just quickly run you through a few cases so that the scenario is quite clear. This is the thyroid newborn screening of a healthy term baby of 2.95 kg. We do cord blood, so the cord TSH was 163, but all cord TSH is above 25. We repeat after 72 hours. And the repeat values are taken for diagnosis because some of the high cord values will normalize by 72 hours. So at the repeat time, the TSH is again elevated, and you can see that the free T4 is very low and the T4 is also very low. So how will you interpret these results? This has been said again. So we also did a technetium 99 scan. This is in the early days. And even now we do a technetium 99 scan. And you can see that there are markers put there. One is at the suprasternal notch and then the chin. And in between that is the area. And no thyroid tissue was seen. So this is a thyroid agenesis. There is no uptake even in ectopic area. So this is a clear-cut thyroid agenesis or athyrosis. So the second case is very similar. Again, a 39-weeker, 2.8 kg, cord blood TSH was 95. But you can see here the 72-hour TSH went up to 150. Again, we have a free T4, which is very low. And the T4 is also low. We have given the age-appropriate values by its side. Again, you can see there's a technetium 99 scan with no uptake. Again, we would say it is a athyrosis. But what happened when we regularly followed up this child was there was normalization of the free T4 by 4 weeks at 12 micrograms per kg per day. But serial measurements over the next 24 months, we found that there was no need in L-thyroxine requirement. And so what will you suspect? So this is where we looked at apparent athyrosis. Now, apparent athyrosis is a condition where the technetium 99 scan is not uptaken, but the thyroid tissue remains normal. Most of the cases is because of maternal TSH receptor blocking antibodies. So here this is a transient phenomena, and it doesn't continue, but it can occur in subsequent pregnancy. So the next sibling also can be involved, where they will initially have mild transient hypothyroidism, and the technetium 99 or I-131 scans, there will be no uptake. But if you do an ultrasound, you will see the normal thyroid tissue. It also happens with one of the first step of the thyroid hormone synthesis, that is the sodium iodide importer defect, because there is no uptake, iodine is not taken up into the gland. Similarly, the dye also won't be taken up. So you'll have a dyshomogenesis again, where there is apparent athyrosis, or it also can happen with TSH receptor inactivating mutations. So apparent athyrosis can be a transient hypothyroidism, or if it is a sodium iodide importer defect, it can be a permanent thing. So it's good to know that there is something of that nature. And case 3, again, I'm going to tell you, this is a 3.5 kg neonate, was born with diurnal aprasia and was operated on day 2. He recovered on day 5, and then he started noticing jaundice. And like all clinicians in the nursery, as soon as there is jaundice and unexplainable, thyroid functions were done. And you can see these values. There is a high TSH, low T4, and very low T4. So there is a primary hypothyroidism. Now, what would you think this primary hypothyroidism is? This is just to show that we have to be looking at the clinical background as well when we interpret thyroid test. No patient should be diagnosed just based on what results you see on the screen or on the lab report. The clinical scenario should be the background on which the biochemical test should be interpreted. Actually, this was a Wolff-Chaikoff effect because of the dural atresia, excessive iodine exposure with the betadine paint during surgery, and there was a transient inhibition of synthesis, and also this is an autoregulatory mechanism, and the same thing, excessive iodine will cause the technetium 99 scan to show athyrosis, and this is more pronounced with immature newborns, and it has to be remembered whenever your babies are exposed to extra iodine, you have to remember that the thyroid functions may be transiently elevated. I'll go to the last one more case where this is an 80-day-old. So remember, it's about the 2.5 months. We are seeing this baby was referred to us for inadequately controlled congenital hypothyroidism. So term baby born by normal vaginal delivery with a birth weight of 3.2 or 3,200 grams. And somewhere in the local hospital, he was diagnosed on day 20. He was started on levothyroxine, 37.5 micrograms daily. I'll come to you to the values of how he was diagnosed. There was no remarkable family history of any thyroid disorder and no history of any maternal medications or thyroid disease. And on examination, the baby was healthy. There was no goiter. The weight at 80 days were okay, and the length was also all right. So this is a healthy baby, actually. So these were the serial tests which were done for this child. And if you look at day 20, will anybody be able to comment? Day 20, looking at this results is why they started thyroxine. Actually, the free T4 was not looked at, I think. They saw the TSH of 7. They did not use age-appropriate values. They probably looked at adult values because you know that in the newborn period, the first month and even up to the second month, the TSH can be normally elevated up to 10. There are different values given anywhere, but we cannot use adult ranges of TSH to analyze thyroid TSH values in the newborn age. So here there is actually a TSH which is normal, which was mistaken for a high TSH, and the total T4 was low, though the free T4 was normal, very much normal. So they started thyroxine on day 20, and you can see by day 50, day 64, day 74, day 78, the TSH is getting suppressed. The total T4 is remaining low. If you look at the total T4 alone, you will think that the child is hypothyroid. But the free T4, you can see it is going beyond the physiological range, and that is why the TSH is getting suppressed. 2.6 also will work in a normal, up to 2.6 is all right. But once it reaches 3.8, you can see that the TSH is getting suppressed beyond the normal values, and this is an iatrogenic hyperthyroidism. So this is how, though the doses were all right for kg, they were giving 10 micrograms per kg. What happened was the free T4 was getting elevated, TSH was suppressed, and only the total T4 was low. This is called congenital thyroid binding globulin deficiency or TBG deficiency, which can occur, usually occurs in male because it's an X-linked thing. We did an ultrasound where they showed a normal thyroid gland. Awareness is very important regarding this because it will prevent unnecessary investigations and treatment for unnecessary hypothyroidism resulting in hyperthyroid states. This definitely does not cause any metabolic effect and does not need treatment. So I'll come to the learning points. So we need to know etiological diagnosis to confirm a permanency and to plan lifelong treatment. Replacement therapy should be commenced within the first 2 weeks to avoid a negative neurocognitive sequelae, and it should be with appropriate doses of levothyroxine. And we need regular follow-up, both clinical and biochemical. Dose modifications are crucial for the successful management. If you have a doubtful case, we will reassess at 2.5 to 3 years after discontinuing the thyroxine for 6 to 8 weeks. Now, are there any side effects of thyroxine overtreatment? Definitely yes. There are short-term risks, tachycardia, nervousness, disturbed sleep pattern. And are there long-term risks? Yes. Bone age advancement, learning difficulties, hyperactive behavior, osteoporosis, even premature cranial synostosis can occur if you overtreat with thyroxine. And these effects are actually quite deleterious in a young age group. So with that, I will end my slide. And if there are any questions or something to take, we can do that.
Thank you, ma'am. Very informative and useful lecture. We can take 1-2 questions if anybody has. So there are no questions, ma'am. Thank you, ma'am.
Thank you. Thank you for
So now I
patiently
hand over to
listening.
Dr. Vijay Jaiswal for the second case. Vijay Jaiswal, sir.
Thank you, ma'am, for a very nice and lucid presentation, including the interesting cases. And this was really eye-opener for all of us and for especially for postgraduate. So the second case is that apart from that congenital hypothyroidism, now the second case is of acquired hypothyroidism. And this is going to be presented by Dr. Naveen Kumar Pillai under mentorship of Dr. Anjali Verma. She is associate professor and at PGI Rohtak. And the examiner is none other than our learned ma'am, Dr. Vandana Jain, ma'am. So she is professor at Department of Pediatric Endocrinology at AIIMS, New Delhi. And she is coordinator for DM Pediatric Endocrinology program. And she is having so many accolades to her, and she is actively involved in research, and many publications are there. So over to Dr. Naveen for doing presentation.
Yes, sir. Am I audible, sir? Am I
Yes, yes.
audible, ma'am?
Yes, 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 you
Am I
are.
You are
visible?
audible. Yes.
Screen is also visible.
Yes, yes. Good evening, one and all. My name is Dr. Naveen Kumar Pillai, and I'm a second year postgraduate resident in Department of Pediatrics. My guide is Dr. Anjali ma'am, Associate Professor of Pediatrics Department, PGMS Rohtak. I'm going to present a case of acquired hypothyroidism. The child is a 6 years, 6 months old child named Tamanna, a female child, daughter of Parvinder Kumar and resident of Danana Bhiwani and belonging to religion Hindu. The informant is father, and which history is reliable. The child presented with the chief complaints of not growing as per peers for last 3 years and bleeding per vaginum and constipation since 5 months. History of present illness. Child was apparently normal and growth was also normal uh, till 3 years of age. After that, father noticed the child is not growing height as per her peers for last 3 years and not outgrowing her clothes or shoes for long time, and younger sibling taller than this child. Bleeding per vaginum for 5 months, insidious in onset and associated with spotting and pain abdomen, which is cyclical in nature, and bleeding every 15 to 20 days lasting for 3 to 5 days. And there is history of breast enlargement for last 8 months, not associated with pain or milky discharge from breast. And constipation for 5 months. uh, the child used to pass stools in 2 to 3 days, hard in consistency and associated with painful defecation. And there is history of decreased appetite and cold intolerance and decreased social interaction and doesn't play with other children. And there is excessive sleepiness, and there is history of laziness and lethargy. Coming to negative history, there is no history of axillary or pubic hair growth, no history of pain abdomen or vomiting or any mass felt, no history of hair growth over body, no history of acne or body discharge or vaginal discharge, no history of rapid growth rather child is not growing, no history of trauma or sexual abuse, no history of drug intake or application of any creams like estradiol cream, no history of headache or visual impairment or seizures or behavioral change, and there is no history of head trauma, CNS infections or any tumors. And there is no history of fever, cough, or weight loss, and no history of bleeding from other sides, no history of swelling of neck or difficulty in breathing or difficulty in swallowing, and no history of delayed dentition or swelling over the body, and there is no history of similar illness in the mother, and there is no history of hearing loss, and no history of polyuria or polydipsia or loose stools or abdominal distension. Uh,
Can I just
this is
stop
the
you?
negative. Yes,
Yeah,
ma'am.
Dr. Naveen.
Yes, ma'am.
So First thing is that generally we don't give identifying details, especially when we are presenting history on an open online platform.
Oh, okay, ma'am.
That's okay. So then when you're presenting your case, typically if a child has bleeding PV, then it is
Yes, ma'am.
unlikely that the parents would also give you poor growth as a presenting complaint, because when something so dramatic occurs in a
Yes, ma'am.
6-year-old child, she starts having bleeding PV. So typically that would be the presenting complaint. Other things would probably come up when you take the history, but they would usually not be the presenting complaint. That is one thing.
Yes,
Then your history is really very good. I mean, you've tried to think of various possibilities. We can see that you're thinking of various causes of precocious puberty in this child. Also,
yes,
you're
ma'am.
trying to look at what are the other manifestations of hypothyroidism that this child has.
Yes, ma'am. Yes, ma'am.
But can you just tell me that, what are the thoughts in your mind when you took this negative history? So, what were you thinking of? So, in this child, offhand, when she came to you with the history of bleeding PV and with breast development, what were the possibilities that you considered? And specifically, I could not understand why you've asked no history of similar illness in the mother. So, maybe you could tell a little bit about this.
Yes, ma'am. Actually, the child presented with the complaint of bleeding per vaginum, and previously breast enlargement is also there, ma'am, which is corresponding to like precocious puberty, and there is also there is also hypothyroidism. I have taken the negative history of hypothyroidism also, ma'am, because the child was having short stature on examination, short stature, anthropometric according, and we have
But you have other
investigated the
definitions in
lifetime.
your
Yes, ma'am.
mind? Yes.
Yes, ma'am. Precocious. First one is precocious puberty, ma'am, which can be central or peripheral precocious puberty, and sometimes hypothyroidism can also present like precocious puberty, ma'am.
One
And
is you're thinking of hypothyroidism presenting as precocious puberty. So,
there
what
may
are the
be
other causes? So, in central, what are
isolated,
the causes? And in peripheral, what are the causes that you're thinking of?
ma'am. In central, uh, causes of CNS tumors like hypothalamic hematoma and all, and peripheral causes McCune-Albright syndrome, ma'am, and there may be cysts due to excess estrogen excess from adrenals or estrogen excess from ovaries. These can be the causes, ma'am, like isolated thelarche and congenital adrenal hyperplasia.
Congenital adrenal hyperplasia,
But
typically it
peripheral
is not present.
precocious, yes, ma'am.
So, that is the most common cause of peripheral precocity in boys.
Boys, ma'am. Yes, ma'am.
In girls, it would be unusual that the child would present with peripheral precocity due to CAH. Okay, what else are you thinking of? You said McCune, all right. First of all, can you tell me that based on your history, were you thinking more in terms of peripheral precocious puberty or central precocious puberty?
According to my history, I'm going to more towards peripheral precocious puberty, ma'am, because uh, menarche was achieved within 3 months of it is according to discordant precocious puberty because menarche is achieved within three 3 months of thelarche, ma'am, and it may be one of the manifestations in peripheral precocious puberty only because of hyperfunctioning of ovaries and estrogen release.
Yeah, so that is a very
So
strong pointer.
yes, ma'am.
Do you think that not gaining height is also a pointer towards either central or peripheral precocious puberty?
Ma'am, actually, precocious puberty, we usually see uh, we won't see short stature, ma'am.
Hmm.
Uh, but in this case, we are having short stature, so we have investigated the child and we thought of hypothyroidism.
That is
Because
true. That
hypothyroidism
is
is
true. So
only
basically, my
case.
point is that if precocious puberty due to any etiology, whether central or peripheral, typically both would be associated with a growth spurt. But in girls, when we talk about peripheral precocity, the causes are like one is hypothyroidism, another one is McCune-Albright, another one is functional ovarian cysts. So in these cases, sometimes the precocity isn't like it's not continued. If there is a cyst, it will produce estrogen for some time and then it will stop producing. So typically, girls with peripheral precocious puberty may not show an increase in stature. But it's not that central versus peripheral decides that. It's just because that estrogen production was short lived in girls with peripheral precocity. If we were to look at boys with peripheral precocious puberty, where CAH is the commonest cause, then they would have growth spurt, even with peripheral and, of course, with central. So, with either central or peripheral, they would have growth spurt. Why did you ask about history of similar illness in the mother?
And sometimes in hypothyroidism, if you're considering hypothyroidism, then similar illness in hypothyroidism, mother can also have hypothyroidism, ma'am, and mother may be on some hypothyroid drugs.
Yeah, but here the child's main concern was bleeding PV, so that would not be a similar illness in the mother.
Yes, ma'am.
Another important cause
Familial
of peripheral
precocious
precocious.
puberty
Yeah,
to
familial
rule
is.
out
What is
to
familial
rule out
precocious puberty?
means, ma'am, sometimes it can be associated with in parents also there can be precocious puberty, ma'am.
That would be very rare. Typically, in males, you may have familial testotoxicosis. So, one sibling after another. So, like two boys of the same family may present to you with familial precocious puberty. That's a peripheral precocious puberty. That's another thing. Girls typically, you may say that if the child had early menarche, let's say at borderline 9 years, something like that, then possibly, the age at menarche may have some relationship between mother and daughter may have similar age at menarche. But okay, I think we can proceed forward unless Dr. Anjali wants to ask something.
But in addition, I just want to say, ma'am, he has taken history of application of creams and
Yes.
that is also an important cause
Yes,
of
that is also
peripheral
very important
precautions.
cause. Yes,
Oh,
in girls
very-
especially. Yes.
And of
Yes.
course, history of trauma was also taken, although there is breast development. So basically, so it is not possible.
Please proceed.
Yes, ma'am. Past history. There is no history of similar illness in past and no history of any usage of medications and no history of previous CNS or neck surgery or irradiation. Antenatal history was uneventful, spontaneously conceived, maternal diet was adequate and balanced, and not on any regular drug intake. Mother was not on any drug intake, and there is no history of decreased fetal movements and no history of abortions. Birth and postnatal history, the child was spontaneously conceived and institutional delivery preterm 33 week SGA 1.29 kg, normal delivery, breech presentation, cried immediately after birth, admitted in NICU for 10 days in view of prematurity and low birth weight. And the child wasn't screened for congenital hypothyroidism, and there were no history of signs and symptoms suggestive of hypothyroidism. In developmental history, the child was normal as per age in all four domains, but the scholastic performance was average. The child studies in class 1, got admitted in lower standard because of decreased scholastic performance and decreased social interaction and lethargic for 3 years now. Immunization history, BCG scar was present and completely immunized as per age. Family history from the
Just
child.
a minute, Naveen. You said
Yes,
that
ma'am.
the child got admitted in a lower standard because of decreased scholastic performance.
Yes, ma'am.
I think if you would have taken more detailed history, you would probably find that they might be worried because her stature was short or because she was lethargic, so she did not feel like going to school. Typically, if a child, if it is acquired hypothyroidism, not congenital, so as you had said, her scholastic performance is average. So once she's going to school, she's able to perform at par with her peers. And this is the general history that in acquired hypothyroidism, they are typically doing okay in school because
Yes,
they are,
ma'am.
they are not distracted easily. If they're sitting and studying, they will just sit and study. They'll not look here and there and don't want to go out and play. So typically it is seen that once you start them on treatment, their academic performance may go down a little. But the parents are happy with that because they realize that this child is now normal and was not normal earlier when she was just sitting and studying. Yeah.
Yes, ma'am.
Okay.
Can I ask one thing, Naveen?
Yes, ma'am.
Yeah. In the past history, can you go to the past history, please?
Yes, ma'am.
No history of similar illnesses past. So why this thing? Matlab, this is a condition which can recur.
No, ma'am.
The similar illness in past. So what did you have in mind actually?
The presenting complaint was bleeding per vagina, ma'am. Some bleeding in view of bleeding tendencies, bleeding manifestations. If they are recurrent and all, I've asked in view of that, ma'am.
Okay, go ahead.
Yes, ma'am. Coming to family history, the child is first order child born out of non-consanguineous marriage, and there is history of thyroid disorder in aunt, and she was diagnosed in 2017 and on thyroid medication since then. And there is a history of seizure disorder in younger sister on, and the sister was on Levera. And mother Minarki age were 14 years and father age of shaving was 17 years. There is no history of genetic or syndromic conditions in family, and there is no history of TB contact in family. Coming to psychosocial and nutritional history, the child was taking a daily intake of 1348 kilocalorie per day, but the required energy calorie intake according to her age is 1600 kilocalorie per day, which gives a deficit of 252 kilocalorie per day. And protein intake of child was 14.5 gram per day, but the required is 20.1 gram per day, which giving a deficit of 6 gram per day. And there is no history of abuse or stressful family environment, and no history of consumption of high fat diet or excessive consumption of phytoestrogens like soy based products. Coming to socioeconomic history, the family corresponds to like middle class, three of according to moderate to Swami scale. Summary, according to my history, this is a 6 years 6 months old female child, first order child born out of non-consanguineous marriage, studying in first class with average scholastic performance, with chief complaints of not gaining height noticed for 3 years and breast enlargement from 8 months, followed by bleeding per vaginum for 5 months. There is history of thyroid disorder in maternal aunt, and my provisional diagnosis is discordant precocious puberty along with short stature. On general physical examination, the child is dull-looking child. Vitals are stable, but child was having pallor, and there is no icterus, no cyanosis clubbing, no lymphadenopathy, no pedal edema or edema at any other sites. On head-to-toe examination, the head is normal in shape, but a child was having coarse and brittle hair, and coarse faces and facial puffiness is present. Nose was broad with flattened nasal bridge. Neck was short and broad with no thyroid swelling. Skin was coarse, thick, rough, dry, and cold skin. No white spots or cephaloid spots on skin. Eyes, widely separated eyes. No eye signs suggestive of hyperthyroidism, and iris and pupil are normal. Ears are normal. No preauricular tags are seen. Oral examination, dentition was normal and no macroglossia. Nails are normal and genitalia normal. Sexual maturity staging B3, P1, A1. Anthropometry and growth chart. The height per age corresponds to like less than third centile, Z score minus 4.53 standard deviation. Weight for age corresponds to less than third centile, minus 3.86 standard deviation. BMI was 13.3 kg per meter square, which is underweight. Height is, we can see height is more affected than weight according to growth chart plotting. And mother's height is 155 centimeters and father's height is 170.5 centimeters. MPH is 163. Upper segment lower segment ratio is 1.3:1, and chronological age is 6 years 6 months of this child, but height age is 2 years 6 months and weight age is 1 year 10 months. X-ray, this is X-ray wrist of that child, and it corresponds to the bone age of 2 to 3 years.
The child's weight was more affected than the height. You said weight age is 1 year
No.
and 10 months. Weight age is lower
Yes.
than the height age.
No, ma'am. I think in Z score, the height for age was minus
Yeah, Z scores.
4.53. Z
Yeah.
score.
I think we should not really give too much importance to this height age, weightage business, because I've seen
Okay.
lately a lot of people are discussing more in terms of height age, weightage. It's really not that useful. One should look at the SDS only, and in BMI also you should have given the BMI standard deviation score. Was it really underweight? What is underweight in terms of BMI for a child? This is a 6.5-year-old child. So the definition of underweight in this age group would be what?
Less the third centile. Weight for age.
Yeah, BMI below the third centile, not weight for
below
age.
third centile. Yes.
So that is anti-nutrition. I mean, children above 5 years, you really don't talk about weight for age. You have to only look at BMI for age and height for age. Okay,
Yes.
and for BMI for age, because we use the IAP growth charts, so typically it is defined in terms of centile only, so below third centile. BMI for age below third centile. So I'm not sure whether this would be below third centile. Typically, it would not be expected in a child with hypothyroidism, acquired hypothyroidism. we know that they usually are of a normal BMI. Height
Yes.
is affected more, and they typically appear a bit chubby or slightly overweight because the BMI is not affected that much. Weight is not affected that much.
Yes.
Okay.
Coming to systemic examination, CVS S1 S2 is normal with apex beta at normal position. Gastrointestinal system slightly protuberant abdomen, no hernia, and no organomegaly was seen. And CNS examination, the child is conscious and oriented, no slurred speech or hoarse voice are seen. DTRs are normal, and respiratory system examination, bilateral air entry was normal, no breath sounds are normal. Musculoskeletal examination, no weakness or cough muscle hypertrophy is seen. Coming to summary after examination, this is 6 years, 6 months old female child, first order child born out of non-consanguineous marriage, studying in first class with average scholastic performance with chief complaints of not gaining height, noticed for 3 years, and excessive growth of breast tissue for 8 months, followed by bleeding per vagina for 5 months, and history of thyroid disorder in maternal aunt. And on examination, the child is dull looking with coarse brittle hair and coarse faces with broad nose with flat nasal bridge with proportionately pathological short stature, height affected more than weight, with SMR staging B3 P1A1 with normal genitalia and no neck swelling. And my provisional diagnosis is, ma'am, discordant precocious puberty with short stature, uh, isosexual and most likely peripheral precocious puberty, ma'am. And my differential diagnosis are, ma'am, first one is hypothyroidism leading to precocious puberty. Points in favor are proportionate short stature and constipation and lethargy and poor scholastic performance, and menarche achieved within 3 months of thelarche, which is discordant precocious puberty. And second differential diagnosis is McCune-Albright syndrome, ma'am. Points in favor of that are peripheral precocious puberty, and points against are no capillate spots, no polyostotic fibrous dysplasia, and features of hypothyroidism and short stature, ma'am. And third DD is estrogenic lesions or tumors of ovary, and points in favor of precocious puberty, but points against of that are short stature and features suggestive of hypothyroidism. 4DD is CH, ma'am. And points in favor of peripheral precocious puberty, points against are there are no signs of virilization, and no the patient is having isosexual precocious puberty and short stature, and there are features suggestive of hypothyroidism.
Okay. So so basically your most important differential diagnosis seems to be hypothyroidism, with the strongest
Yes.
point favoring is that the child is short and her
Yes,
bone age is delayed. So in any cause of peripheral precocious puberty, you would expect bone age to be advanced
advanced.
and height to be either preserved or more. Okay, what thyroid disorder can you see in patients with McCune-Albright syndrome?
Ma'am, in McCune-Albright syndrome, we can see hyperthyroidism, ma'am, but the patient is having hypothyroidism.
Okay. And can you tell me some of the tumors of ovary which can produce estrogen, or functional ovarian tumors in children that can present as precocious puberty?
Ma'am, juvenile granulosa cell tumor, ma'am.
Mhm. So typically, how will you distinguish a tumor from this particular patient's features? So suppose you do an ultrasound and you find ovarian masses or ovarian cysts. So
Yes, ma'am.
can you see it in your patient also when you're keeping hypothyroidism as the first possibility? Or would
Yes,
that
ma'am.
straight away indicate that this looks like an ovarian tumor?
No, ma'am. On ultrasound, cysts in ovary were seen, ma'am,
Mm.
and there is thelarche, which corresponds to that estrogen excess from ovaries.
So can you tell me on ultrasound what would be the appearance of a juvenile granulosa cell tumor versus your patient with hypothyroidism with cystic ovaries?
In juvenile granulosa cell tumor, ma'am, there will be multiple follicular cysts, cystic-like lesions.
It's a tumor, no? So tumor would be typically unilateral.
Laterality, yeah.
Yeah. So typically it will be unilateral, Naveen, and it will be a solid cystic mass. And Van Wyk Grumbach would typically present
Yes,
with
ma'am.
bilateral multicystic
Bilateral
ovaries.
cysts.
So, but unfortunately, some girls do undergo bilateral ovariectomy also wrongly, because they may first present with a big ovarian mass or sometimes with torsion, and because nobody bothers to do a thyroid function, especially if they reach a surgeon or a gynecologist. So sometimes so this is something important that we should know. Okay,
Okay.
please proceed.
On evaluation and investigations, ma'am, the HB was 10.2 gram per DL, which is anemic, and MCV was 85 femtoliter. TLC was 6,460 cells per millimeter cube. Platelets are 1.5 lakhs. Free T3 was 0.87 picogram per ml, which is decreased, and free T4 was 0.08 nanogram per DL, which is also decreased, and TSH is more than 150 micro IU per liter, ma'am, and LH is less than 0.2.
Micro IU per ml.
Uh,
So it's either milli IU per liter or micro IU per ml. Okay.
Sorry, ma'am. LH is less than 0.22 micro IU per ml, ma'am, and FSH is 6.85 micro IU per ml, which is increased, and
No,
prolactin
that
is
is milli IU per ml only. LH and FSH are in milli IU per ml or unit per liter. And for TSH, it's either micro IU per ml or milli unit per liter. So LH, FSH units are okay.
okay, ma'am. Prolactin is 111 nanogram per ml, which is raised, and anti-TPO antibodies were negative, ma'am. On ultrasound, pelvis and head, necks and gonads, bilateral ovaries suggestive of cystic structures of measuring size 2.3 into 1.9 centimeters were seen, and right head neck size having anechoic cystic lesion. Ultrasound thyroid gland was present with both lobes and isthmus with normal ecotexture, ma'am.
So why is prolactin elevated?
Ma'am, prolactin is elevated because of stimulation from TRH, ma'am. TRH can stimulate both TSH and also prolactin. So, due to that stimulation of TRH, the prolactin is raised, ma'am.
Normally, what keeps prolactin low? Dopamine. So
Dopamine.
typically it is like TRH excess may also be the etiology, but typically it is thought that stalk effect, basically because there is typically pituitary hyperplasia. If it's a long-standing hyperthyroidism, primary hyperthyroidism, so the pituitary hyperplasia, that will cause impingement on the stalk. And so the dopamine is not able to come down from the hypothalamus, and therefore that inhibition is less, and therefore prolactin is elevated. So in this child, what is the etiology now? Your anti-TPO antibodies are negative, and ultrasound shows thyroid is normal, and they haven't really said that it is suggestive of thyroiditis either. So what are you thinking of as the etiology?
We have ruled out every cause of hypothyroidism, ma'am. The cause in this child may be, ma'am, iodine deficiency or iatrogenic, ma'am.
So were they using iodized salt?
Yes, ma'am. They are using iodized salt in their home.
They are giving history, actually.
They
We are not able to find out the cause.
And iatrogenic? Why iatrogenic? You saying it could be iatrogenic? Idiopathic? You meant idiopathic?
Yes, ma'am, idiopathic.
I would still think that it has to be autoimmune. I mean, there's a family history also, right?
Yes, ma'am, maternal.
Marcy had it, and then this child has it.
Yes, ma'am.
It's a bit odd. So, can there be autoimmune thyroiditis with negative anti-TPO antibodies?
There can be possibility, ma'am. Yes, ma'am.
So sometimes the antibodies may be negative, and maybe you can repeat it after some time. Maybe you can consider doing antithyroglobulin antibodies. Okay.
Yes, ma'am.
Can ultrasound be normal? Like we have done actually
ultrasound is observer dependent. So
actually we have gone for ultrasound 2 to 3 times because we were also suspecting the most common cause as Hashimoto's, but we were not able to find out anything.
Yeah, it's a bit odd. Okay, so suppose this was autoimmune, Naveen, would you like to look for other autoimmune associations, or would you not?
Yes, ma'am. We had to see for other autoimmune associations, ma'am, like APS, ma'am, autoimmune polyglandular syndrome, and celiac disease, and type 2 diabetes mellitus.
Type 2?
Sorry,
don't screen
type
for. You typically don't screen for these because hypothyroidism is so common that you can't, every child with hypothyroidism, you typically don't screen for celiac, you don't, and definitely type 1 diabetes is not a silent disease. So even in patients with celiac, you typically don't screen for diabetes. In patients with celiac, you would screen for hypothyroidism. Similarly, in patients with type 1 diabetes, you would screen for both celiac and hypothyroidism. But in patients with primary hypothyroidism as the first autoimmune manifestations, you typically don't screen for other things. Although you do have that in the back of your mind that yes, this patient may have APS. Which type? APS 1 or 2?
1, ma'am.
1 or 2? What is APS 1? APS 1 is also known as APECED, epicid. APS 1 is epicid, which is a genetic etiology, AIRE gene mutation, epicid. Typically, hypothyroidism is not part of that. What are the common endocrine disorders in epicid?
Ma'am, IPEC.
Not IPEC, epicid, APS 1, AIRE gene mutation. It's okay. It's hypoparathyroidism.
Primary hypoparathyroidism, ma'am,
Yeah.
and adrenal
And
insufficiency.
adrenal insufficiency. Very good. And these patients typically have candidiasis and ectodermal dystrophy.
Yes.
So that is APS 1. And APS 2 is the one in which hypothyroidism may be a part, along with others like celiac or type 1 diabetes, and rarely even adrenal insufficiency. Okay.
Yes.
Okay, go ahead.
Yes, ma'am. So our provisional diagnosis is hypothyroidism leading to precocious puberty, ma'am. And the child was started on thyroid replacement therapy. Levothyroxine was started, and an outcome height started improving, and bleeding PV stopped, ma'am. On follow-up, this is the X-ray of wrist showing bone age at around 6 to 7 years present, which corresponds to the present age. And this is the growth chart, ma'am. We can see there is
within
improvement
1 year, it seems. Within 1 year, she has 1 to 1.5 years follow. 1.5 years, it seems. 1.5 years, she has reached the 3rd centile. But what is concerning is that the bone age, which was behind by about 4 years, has now caught up.
Yes, ma'am.
So is that good or bad?
Ma'am, bad, ma'am, because advanced bone age may lead to premature epiphyseal fusion, and the target
So it's not
height will
advanced. It is appropriate, but she has not really caught up as compared to her mid-parental height centile. She has not reached her mid-parental height centile yet.
Yes, ma'am.
And still her bone age has caught up. So that means that she is likely to finally have some height deficit. She may not really reach her genetic potential. And that is a concern because this child fortunately presented to you at a relatively younger age. But sometimes we see girls who present at 11, 12 years, and at presentation, bone age is markedly delayed. And at that time, you may predict that she may be able to reach her adult height potential, but ultimately the bone age catches up much faster than actually the height catches up. So they do have height deficit finally. So that is a concern. Okay.
Thank you, ma'am.
Yeah. Thank you. So that was a good case. And yeah, as I said, unfortunately, some girls do end up getting bilateral ovarectomy done as well. So it is something that everybody should be aware of. So that was a good case. Any other questions from others? Are there anything in the chat box, Dr. Javinder? Chat box. Yeah. So there are some questions in the chat.
What can be reasons for this advancing bone age? Can you do something about it?
In this patient after treatment, sir, or in general?
So I'll try to address that as part of my talk also.
Chat box, there are no questions.
Possibly look at that. And okay, so there is one question. During follow-up of child, started any particular time period to follow up biochemically as previous presenter told every 2 months? So Dr. Naveen?
Would you want to answer? How to follow up the child with acquired hypothyroidism?
Frequently.
How frequently?
Yes, ma'am. 4 to 6 monthly follow-up, ma'am. And if there is any
Monthly?
dose, 4 weekly, ma'am. 4 weekly. And then if there is any dose change we are doing, we have to follow up within 4 weeks, ma'am.
So initially, maybe you can follow a little, maybe at 6 weeks to 3 months, but generally in older children, we are okay if their thyroid function is okay it's reasonably stable, then it can be done
3
6
months.
monthly. 6 monthly is also okay. So, but yes, if there is a child who is, that the family has very poor compliance, TSH levels fluctuate up and down, then it's better to keep them under closer follow-up.
Should we decrease the dose of L-thyroxine in this patient? Because, ma'am, what is happening is the TSH is absolutely in the normal range. It is not very much decreased. T4 is not in the, like it is on the higher side, but it is not more than the normal. So should we decrease, thinking upon that bone age is very much progressing and all that?
Yes, so I'll try to address this question during my talk also. So yes, I would agree with that you can keep the TSH slightly higher because you don't want that the bone age should be, it should advance any further and the child would lose height potential. So you can try to keep TSH on the, like in the upper half of the normal range.
Maybe around 3 is okay.
Yeah, around 3 to 4 is okay. Don't aim to suppress too much. Yeah.
So, ma'am, we are running late. We can have your lecture, please.
Can you see my screen?
Yes, ma'am, your screen is visible.
Okay. Yeah. So good evening, everybody. So I'll be talking on acquired hypothyroidism, and after that case by Naveen, I think the stage has already been set. So going on to etiology, as Dr. Anna Simon had also presented, we can divide hypothyroidism into primary and secondary or tertiary, which are both together clubbed as central. So amongst the primary causes, thyroiditis, Hashimoto's is the commonest etiology of acquired hypothyroidism. Apart from that, subacute or acute infectious thyroiditis are also known. After that, another etiology is drugs, amongst which anti-seizure medications are the most important, and especially valproate. Then infiltrative causes like iron overload states, as in hemochromatosis or thalassemia, and cystinosis also it's known to cause primary hypothyroidism. Then iodine deficiency, radiation to the neck, very important. For example, we often see children with previous cancers, especially Hodgkin's, who may present with the primary hypothyroidism later. Then thyroid hormone resistance is an uncommon cause, but you have to suspect it when you see that your TSH is high as well as your free T4 is high, but the patient is having features of hypothyroidism. So that is thyroid hormone resistance. And then late presentation of congenital hypothyroidism. So unfortunately, many children, they may present quite late in older age group, but it may still be congenital hypothyroidism. And as we know that those with ectopic thyroid, they may have some degree of preserved thyroid function. So they may not really present with, very frank features like we suspect in congenital hypothyroidism. So they may mimic an acquired hypothyroidism. Then amongst the central causes, supracellular injury due to tumor, surgery, or radiation and trauma. For example, craniopharyngioma survivors, children with various CNS tumors who have received radiation to the central nervous system, they may present with central hypothyroidism. And infiltrative disorders, including tuberculosis, LCH, and lymphocytic hypophysitis. So Hashimoto thyroiditis or autoimmune thyroiditis or chronic lymphocytic thyroiditis, this is the commonest cause. And the prevalence is roughly 1 per 1,000 school-age children, although some studies have shown even higher prevalence of up to 3 to 5 per 1,000 school-age children. It's more common in females with a 3:1 ratio of female to male. And family history is commonly present. Anti-TPO antibodies are typically positive, and ultrasound is suggestive of thyroiditis. Goiter may or may not be present. Thyroid function is also variable in patients with Hashimoto or autoimmune thyroiditis. Some may have even hashitoxicosis, that they may have low TSH and elevated free T4 or T3, and with reduced, but importantly, they would have reduced radioactive iodine uptake as compared to Graves' disease, where the RAIU would be increased. Or sometimes they may present with a euthyroid goiter, which we all know that when a child presents with goiter, again the commonest cause is Hashimoto. But remember, all Hashimoto's don't present with goiters, and all goiters are not hypothyroid. Then associations, as we were discussing, one is with autoimmune polyendocrinopathy syndromes, more with type 2, less with type 1. And with syndromes, so Down syndrome, Turner syndrome, Luna and Klinefelter, they are all at higher predilection for developing autoimmune thyroiditis. So in children with Down and Turner, we know that we typically screen for hypothyroidism, even if they are asymptomatic. So clinical features, most important clinical feature is deceleration of growth. And children typically have periorbital or generalized puffiness with mild overweight. So they typically don't have frank obesity, but they're mildly overweight. Delayed osseous maturation with delayed puberty is the common presentation. Please remember that Van Wyk-Grumbach syndrome, which Naveen had presented, is uncommon. Most children would have a delay of puberty. Then constipation, dry skin, cold intolerance, somnolence, lethargy, and learning difficulties may be there. But again, as I said earlier, they're typically good in scholastics. Why? Because they're just sitting and studying. So of course, they may have difficulty in doing something which requires a lot of, interpretation or analytical skills, but something which just requires rote learning, probably they will be okay with that. Then GnRH, independent precocious puberty, we've already seen the case, and pseudomuscular hypertrophy or the Cocker-Debris syndrome, which may sometimes be the presenting complaint. And sometimes these children may mimic something like a Duchenne muscular dystrophy because they may have this similar appearance and with mild weakness as well. So diagnosis is often missed, and this child had actually presented to me just about 10 days back. So I took a picture, and she was about 10 years old, and her height was about 110 centimeters. She was quite short. But the main complaint which the mother said was vague aches and pains, like joint pains. And with this complaint, she had actually went to a good central institution, a teaching college, where she was admitted and she was worked up for collagen vascular diseases. And her RA factor came mildly positive, and she was investigated on those lines. She was started on treatment for that. And actually, she was not investigated further. So because the child did not really receive any benefit from the treatment, she was lost to follow up. And after a year, she presented to our OPD. This is a classic case. When you see her, you can see the periorbital puffiness. She is very short. Now she smiled for the picture, but otherwise she was looking quite dull. So when I just called my own GRs and asked them what is the diagnosis, and with this history of joint pains and all, they also said it's likely to be JIA. So remember that hypothyroidism is much more common. It's as we saw, it's this Hashimoto alone is 1 per thousand, so it's much more common than GIA or other etiologies. So please don't miss hypothyroidism. This child clearly had hypothyroidism. TSH was more than 500. She could have been diagnosed 1 year back. So she lost that 1 year of growth. Anti-TPO was elevated. She did not have a goiter. So goiter is not a sine qua non for acquired hypothyroidism or Hashimoto's. Another child, 8-year-old, quite short. Height was just 89 centimeters, -6 SDS, BMI at 50th centile. She had a dull look, sparse hair, puffy face, sallow complexion. Bone age was less than 3 years. T4 was very low, 0.9. We know that the normal range is somewhere from 5.5 to about 12. TSH was very much elevated. Anti-TPO was negative. Ultrasound showed hypoplastic thyroid. So this was probably a congenital hypothyroidism, which was diagnosed late. And this is on follow-up. After about 1 year, she had gained quite significantly in terms of height. But again, as we discussed, bone age may actually catch up and she may lose some of the height potential. So management is with L-thyroxine. You start with a low dose in long-standing hypothyroidism and then gradually increase. So why is that? Why do we start with a lower dose? Maybe some of you can reply in the chat boxes. So there are multiple reasons. One is that the child has adapted to a very low BMR. So we suddenly don't want to increase it. This may lead to some complications, including heart failure. Pseudotumor cerebri is also known. And sometimes even adrenal insufficiency is precipitated if you treat very rapidly. So you have to start with a low dose and then gradually build it up. And another thing is that, as I said, treatment may be associated with rapid bone age advancement. So in short children, it is preferable to keep TSH in the upper range of the normal. Age-wise dosing. So this is like from the congenital hypothyroidism guidelines, that how we keep on decreasing the dose as the child becomes older in terms of microgram per kg. So similar kind of thing we can use, but for acquired hypothyroidism, we actually are guided more by the TSH rather than just by the age. So, for example, if the TSH is just about 15 or 20, then you could start even in an older child who is 20 kg, you must just start with 25 microgram. And if the TSH is very much elevated, as we saw in the previous child, more than 500, again, you start with a lower dose of 12.5 and you gradually build up. And whatever it takes to keep the TSH in the normal range and free T4 in the normal range, you have to titrate according to the TSH and T4. So you monitor 3 monthly initially and then 6 monthly. Once the TFT are stable, then you can monitor 6 monthly. When you get a TFT which is out of range and you have changed the dose, then you have to definitely call back within 2 to 3 months and check. Patients with poor compliance, you need to keep them in closer follow-up, because sometimes otherwise they may just be lost. If you tell them to come after 6 months, they may not even come back for follow-up. So you have to monitor not just TFT, but also at each visit you have to monitor the growth, and you have to plot on the growth charts. You have to look for puberty. And bone age, you can intermittently check, especially when height is a concern. So you don't want the bone age to be rapidly advancing while you're not looking. In children with goiter and mild hypothyroidism, you may give a supervised trial of stopping thyroxine after completion of growth. So this is a conditional thing. For example, many times we see a child with pubertal goiter with the thyroid level, which is just like borderline 13, 14 TSH. Then in such children, after the growth is completed and you've seen that the child has been consistently maintaining euthyroid status with a very low dose of thyroxine, then you may consider giving a trial of stopping. So coming to a question, a 12-year-old girl who was a case of Hashimoto thyroiditis in follow-up, diagnosed 2 years back with initial TSH of 120 milliunits per liter, presented to the OPD for review of recent thyroid function test, and TSH was 9.5, which is high, and T4 is 16 microgram per deciliter, which is also high. So it is, how do you manage this? What do you think is happening here? So when you have increased TSH with increased T4, it could indicate either a recent improvement in compliance, a child who has not been taking, and then when she knows that a test is going to be done, she will start taking, and maybe she will take an extra dose. So sample timing within 4 hours of thyroxine, recently started treatment. If you're doing it prematurely, TSH will take time to normalize. Typically, that is why we don't do it before 2 to 3 months, because TSH will take that much time to normalize. So if you've done it quickly, then T4 will normalize while TSH will still be high. Or a high feedback inhibition threshold, that happens sometimes in infants. When you have high TSH with low T4, then of course the most important thing is poor compliance, but also think of fake medicine, which is unfortunately not uncommon. We commonly see patients taking various brands, and therefore it is preferable to prescribe levothyroxine by a trusted brand. Inadequate dosing, of course, can be a possibility. So basically, it's not that you have a knee-jerk reaction that you see increased TSH low T4 and you increase the dose, because as Dr. Anna had also pointed out, if suddenly the child decides to start taking it regularly, and then the dose was on the higher side, then she may end up having hyperthyroid features. So another case, I think this we can leave. This is a typical case of Van Wyk-Grumbeck, as Naveen had already presented. So we can leave it. Third case, a 12-year-old girl presented to her local hospital with 3 months history of frontal headache, visual disturbance, lethargy, and dizziness. On examination, she had short stature, was prepubertal. She had dull appearance, dry skin with no goiter, and heart rate was 52 per minute, which is low. MRI showed a pituitary tumor impinging on the optic chiasm, and that was responsible for her visual disturbance as well. And prolactin was 80. So what do you think is happening here? So it could be a pituitary tumor which is secreting prolactin. Could that be the etiology? Unlikely, because prolactin is not that high. And the commonest pituitary adenoma is prolactinoma. And typically the prolactin would be much higher than this. It would be at least typically more than 200 or even more than 500 and sometimes even more than 10,000. So this does not look like a prolactinoma. So she was short. She had features of hypothyroidism. You have to look for hypothyroidism. So TSH was elevated and other hormones were normal. And prolactin, we already discussed why prolactin is high. So this also, sometimes these children present to neurosurgery and may unnecessarily undergo a neurosurgical intervention when all they needed was just thyroxine replacement. So be wary of these unusual presentations. Always think of hypothyroidism because it is one of the commonest endocrine disorders in children. Another case, a 12-year-old boy comes with complaints of increased weight gain for the last 2 years. BMI is more than 27th adult equivalent centile. Height is at 90th centile, while the mid-parental was on 50th, so he's tall, and with no symptoms of hypothyroidism. But a TSH was done, as is commonly done in patients with obesity. So TSH was 8, T4 was 8.5. So normal T4, elevated TSH. What is this condition known as? Subclinical hypothyroidism. So is this high TSH the cause of obesity? No, it's not likely to be the cause. So would you treat? No, you would not treat unless there is something else which is pointing towards a primary hypothyroidism. So this child was tall. If there was a family history or there was a goiter, you would investigate him further. Otherwise, you would simply ask him to repeat the test after a few months and you would reassure the family that this mild increase in TSH is a consequence of obesity. So TFTs are ordered very frequently because of commonly we order them for any child with obesity, although it's not indicated. Children who are typically tall, they are exogenous, you need not look for TSH. In the workup of fatigue, in children with family history, in short children, then in patients about to start or patients taking psychoactive medications, in children with precocious or delayed puberty, in girls with irregular menses. So you commonly order TFT and then you commonly encounter some problems. So like TSH may be elevated or sometimes both may be elevated. So you have to really think of why you ordered. Does the patient have features suggestive of hypothyroidism, and then proceed further. So subclinical hypothyroidism is when the total of free T4 are normal and TSH is typically slightly elevated, that is between 4.5 to 10. So it may be because of random TSH variation. There is a diurnal variation in TSH. So TSH peaks after midnight and it is lowest in the late afternoon. So it is something like opposite of what you would see in cortisol. Peak value can be actually double the value at the nadir. So if you do it very early morning versus you do it in the late afternoon, there may be a very significant difference. And again, between there is a random day-to-day variation as well. So you don't rely on one single measurement, especially if it is not very high. Non-thyroidal illness is another cause. Mild autoimmune thyroiditis may present with subclinical hypothyroidism. Mild developmental abnormalities or mild dyshomogenesis can also present like this. So it can be sometimes something which requires follow-up, but mostly it is something which is not very important. Iodine deficiency, obesity, drugs, these are all the causes of subclinical hypothyroidism. So over long term, it is seen that TSH normalizes in 60 to 70% patients. It remains stable in 30 to 40% patients. So it's actually in a very small proportion, it increases over time. So risk factors are in girls or in those with TSH more than 7.5. So if TSH is below 7.5 in a boy, very little chance that it's going to proceed to clinical hypothyroidism. And so you are very right in not starting any treatment. Don't act on single value. Repeat after 4 to 12 weeks. Ask for family history, medication history, look for goiter, syndromic features, check anti-TPO antibodies. Consider treatment if TSH is more than 10 or there is a goiter with TSH between 4.5 to 10. If no goiter, TSH is below 10, you can repeat after 6 to 12 months also. But closer follow-up may be required in those with positive anti-TPO or syndromic children, light and Down syndrome, or in those on medications. Okay, coming to another case, a 9-year-old boy with the case of myoclonic seizures, referred from Ped Neuro OPD for review of thyroid profile. The child has been seizure-free on valproate therapy since 2 months. It should be for the last 2 months. The thyroid profile was ordered in view of recent complaints of constipation and weight gain. So TSH is 7.5 and T4 is 5.2. So here T4 is also according to the lab reference range. It is on the lower side with TSH on the higher side. So it's possibly mild hypothyroidism and possibly related to the anti-seizure medication. So there was a good paper on effect of anti-seizure medications on thyroid function. It is a original paper in which they actually looked at 223 children with epilepsy who were treated with either valproate, which was the commonest one, 129 children, phenobarb, carbamazepine, oxcarbamazepine, or levetiracetam. And they found that all AEDs except Levira affected thyroid function. So actually this red one is valproate. This is free T4. It decreases after starting valproate. TSH increases after starting valproate. And this green one is carbamazepine. So here also you can see that there is a significant decline in FT4 and a rise in TSH, although the TSH is then subsequently coming down. So they said that Levira really did not affect thyroid function much, although the number of patients on Levira was only 11. So I'm not very sure about this particular statement. 25% of those on valproate developed subclinical hypothyroidism. So evaluation of TFT should be considered on children receiving valproate or carbamazepine. What is the mechanism? Increased clearance of T4 is the mechanism. So several other drugs also affect thyroid function, and important ones I have listed here. So bile acid sequestrants, they're not very commonly used, but in those patients who are on these drugs, you have to evaluate for TFT. Calcium carbonate, iron sulfate, they may interfere with thyroxine. So remember that those patients who are on thyroxine should not be taking the medication with these drugs. That is the important thing. Again, a patient is on thyroxine and then you've started pantoprazole because of gastritis or something that can interfere with the absorption of T4. So T4 has to be taken on empty stomach first thing in the morning and should not be taken with any other concomitant drug. Then inhibition of thyroid hormone synthesis or release, of course, with all of these drugs, which are thienamides, lithium, iodine. Suppression of TSH by dopamine. So we know that this is actually relevant for when you're doing newborn screening and the baby is sick on dopamine, so TSH may be falsely low, or so you may miss a true hypothyroid baby who's on dopamine. Glucocorticoids, octreotide. So octreotide we use, for example, in patients with CHI or in patients with portal hypertension, so that they may develop hypothyroidism. And destructive thyroiditis by some cancer treatment drugs like tyrosine kinase inhibitors or immunotherapy drugs. So this I'll leave. Coming to another case, a 5-year-old boy with new onset type 1 diabetes with severe decay with sepsis is admitted in PICU. Thyroid function was evaluated and an endocrinology consult was sought because TSH was 1.8, but free T4 was low, 0.4. So was it central hypothyroidism? No. So this is a sick child, and we know that in sick child, they can have something called a sick euthyroid or a non-thyroidal illness. So critical illness, severe sepsis, surgery or major trauma, malnutrition, anorexia. So this is an adaptive response to reduce the BMR. Mechanism is reduced hypothalamic TRH secretion and increased activity of the deiodinase type 3, which leads to increased clearance of T4 and T3. So fall in T3 is the first one, then T4 and then TSH. So this is the curve that you can see. FT4 is falling like this. FT3 is the first one to fall and TSH falls later. So treatment is not routinely advocated. Then a very rare presentation is myxedema coma, which I'll just discuss very briefly. It's a rare endocrine emergency. And in children, it is often seen as the initial presentation of undiagnosed long-standing primary hypothyroidism. So we have seen 4 or 5 cases in the last 3-4 years. So although prior to that, I had not seen too many. So it is rare, but you have to keep in mind that when you see a child who presents to the ER with these features. So what are the features? Hypothermia, bradycardia, shock can be there. They may have hyponatremia, hypoglycemia, puffy appearance. So keep in mind that this could be because of hypothyroidism. So how do you treat? Of course, with the respiratory and hemodynamic support, passive rewarming. You always start broad spectrum IV antibiotics because it is thought that that tipping point, the child was compensated with the long-standing hypothyroidism, but because of some infection, when the body metabolism tends to increase, then they present with frank hypothyroidism. So you always start broad spectrum IV antibiotics. There is a gradual correction of electrolyte abnormalities that should be instituted. You always have to give stress dose glucocorticoids. Why? Because till you get the reports of T4 and TSH, one is you're not sure whether it is primary or central, but even in primary, as I said earlier, in long-standing primary hypothyroidism, even the adrenal cortex function also reduces. So that is why you don't start when you treat them, you don't start with a high dose. So here in mixed edema coma, when they present, you have to give stress dose of glucocorticoids also. Then thyroid hormone replacement, if the patient is in coma, then you have to give high doses, ideally IV levothyroxine. This is not readily available. So typically we have used nasogastric tube for giving the doses, and this is typically a high dose that you have to give initially. So I think I'll stop here with the key takeaways. So acquired hypothyroidism is one of the commonest endocrine disorders in children. And the commonest cause is Hashimoto thyroiditis. Typical presentation is with short stature with preserved BMI. Generally, they have puffy, dry skin. Sometimes they may have goiter. However, uncommonly, it can present as a space-occupying lesion, ovarian masses, precocious puberty, or even hypothyroid crisis, which is also known as mixed edema coma. So treatment is very rewarding, but close follow-up and good monitoring is very important. Good counseling in the beginning, because many times patients think that it is a course. You write them the drug for 3 months, you ask them to come back after 3 months, they will stop after 3 months and come to you after 9 months. So please remember that you have to counsel very clearly that this drug is most likely they will require the drug throughout life. Thank you.
Thank you, Dr. Vanda ma'am, for a nice presentation and sharing various cases to us. And that was a great learning. And thus, there is one question for you, that what is the chance for resolution of AITD? And it is the sub part is that what is your opinion on tapering the dose in an attempt to discontinue thyroxine therapy post puberty? So this is in chat box.
So basically, as I said earlier, if it is a mild autoimmune thyroiditis, the child has actually presented to you not really with hypothyroid related symptoms, but because of goiter. And then incidentally, you find that the TSH is actually elevated, but not very high. So this would be a typical scenario in an adolescent, let's say 12-year-old girl who comes to you with this, maybe with some menstrual disturbance. She was investigated not for a goiter, but for menstrual disturbance. Again, you found on investigation that she has autoimmune thyroiditis, but the TSH was not very high to begin with. She has always been controlled on a low dose. So then after completion of growth, once she's around 16 years or so, you can consider tapering. Again, tapering and stopping. If everything remains well, of course, as you taper and the TSH doesn't rise, then you can gradually stop. Only thing is you have to tell them that during periods of increased demand, as in pregnancy, lactation, she would again require, there is high chance that she would again require supplementation. So they should be conscious of the fact, the family should be very cautious of the fact that during pregnancy, she would require.
Thank you. Thank you. So thanks for nice presentation. And coming to the next, that is, we are going to do the OSCE, and that is going to be presented by Dr. Ayesha Ahmed. She is professor at Jawaharlal Nehru Medical College, Aligarh. And though we know that the time allotted to you for participation is a bit less, usually 5 minutes you are going to get for OSCE every question, but there is positive after. Just our job is that to sensitize, to acclimatize you that how questions are being asked in OSCE. So over to Dr. Ayesha for your OSCE presentation, please.
Okay, thank you, Dr. Vijay. Though most of the cases have been discussed in 2 invigorating sessions that we had, so I'll quickly run through the OSCEs, and I want participation from all the students and trainees that we have here. Okay. Okay, so can you see the slides and can you hear me?
Yes, you are audible as well as visible. Yes.
Okay, so active participation from all the attendees would be appreciated. So you can either interrupt and talk about the answers. So coming to the first question that we have a 9-year-old girl who presented with history of excessive sleepiness, constipation, and short stature. On examination, there is dry skin, goiter, which was a grade 2 goiter, diffuse, non-nodular, symmetric, and bosselated. On anthropometric parameters, her height is below the 3rd centile and weight is okay within at around the 25th centile. And the investigations reveal TSH, which is high, as you can see from the normal range, with the T4 on the lower side, as you can see. So the questions are from the growth chart, which is given here. Calculate the height, age, and weight age, though, as very rightly pointed out by Vanda ma'am. It's not so important, but for the trainees, just to have an idea, how do you calculate height, age, and weight age? And what other biochemical investigations? We have a deranged thyroid parameters. So what other biochemical investigations are needed here? What is the treatment with dose and how to monitor the child? So anybody from the students, from the attendees, you can unmute
Dr.
yourself.
Aisha, just one interruption. That part A, that is from growth chart, may not be visible and probably they are not going to have growth chart. So at least you can answer B, C, and D. And if it will be prudent if you are trying for A, but if you don't have growth chart, so at least B, C, and D can be answered.
Yeah, definitely growth chart is very important. So you should have an idea. So do I go with the answers or do I wait for the
Just we can wait for some response. Yes, please. So this is for postgraduates only, and nothing is right and wrong. This is learning phase. So just you type your answer. Just give your response.
Very true.
Yes.
Do we have any answers here?
Okay. Dr. Pillai has written something. NTTP.
Can you
Yes,
unmute yourself and give the
They have
answer?
written the doses 2 to 3 microgram per kg.
Okay. So
Okay.
what are other biochemical investigations to be done? Lab investigations? Pillai, you were saying something?
Yes, ma'am. Anti-TPO antibodies need to be done
Very true. Okay.
because Hashimoto's may be most common cause of
Very
acquired
common
hypothyroidism.
cause of acquired. True. Okay. So what is the treatment?
Treatment, ma'am, levothyroxine should be started at lower doses. And
so I think with Dr. Vandana ma'am presentation, we have already got the answer, but Dr. Asha ma'am is going to tell you the answer, correct answer.
Okay. So talking about the anti-TPO antibodies, as you very rightly said, thyroglobulin antibodies, again, that is also shows the autoimmunity, and ultrasound, that is one of the non-biochemical, obviously, investigation, which will help you delineate the diagnosis. So as far as levothyroxine, I think this part again has been discussed very elaborately. So it has to be started at a low dose, especially in long and this untreated hypothyroidism of long duration. And then you have to titrate the dose based on repeat TSH biochemical profiles. So that will help you how to titrate the dose accordingly. So this has been discussed. I think there should not be any confusion. So again, we have a 4-year-old boy who presents with significant speech delay. And his 14-year-old sister has a history of hearing loss and a goiter. So they are born out of a first-degree consanguineous marriage. So here's a catch here, which was again discussed in the talks. So what is the likely diagnosis? What is the characteristic features? How do you confirm? What about the goiter and hearing loss? And what is the mode of inheritance? So if you know about the diagnosis, the rest of the answers, you can do it quickly. So anybody from the students, postgraduate students?
So
Salim, I can see you here.
Dr.
Are you
Naveen
there?
has written the response.
Okay, because I'm sharing, so I can't see that.
Yes.
Okay. So can you read out that for me, sir?
Yeah, he has written Pended syndrome. So can you elaborate Dr. Priya about Pended syndrome, what it is going to be?
Dr. Priya, can you unmute yourself? So it's a discussion, so no need to be scared of anyone or anything. If you know, it's very good. Otherwise, we are here to help you out.
Perhaps he has joined as attendee, so she can't.
Okay, no problem.
Okay,
no
she
problem.
can't unmute. Okay.
So
Okay.
just please.
Okay,
yes,
so Pended syndrome very rightly identified by a few of the participants. So it is characterized by congenital sensorineural hearing loss. So if you remember in the first talk in the child with congenital thyroid, dysfunction and hyperthyroidism, you always look for associated and symptoms and comorbidities, because it is not so common but can be seen. So either they fail the neonatal or infant hearing test, or they may have this hearing ailment later in life, especially about 3 to 4 years of age. And for that, because it's because of deficiency of enzyme pendrin, so you have to, or protein pendrin, so you have to, for confirmation of the diagnosis, you have to order a genetic diagnosis for confirming. And goiter is mostly due to dyshormogenesis, organification defect is here. And you may have association of like a middle ear and inner ear abnormalities, like there is excess of fluid in the internal ear, so which might lead to this hearing loss, which is progressive. So that is why hearing assessment is very important whenever you encounter a child with congenital hypothyroidism, and especially with the history of hearing loss and speech delay, which could have been due to hearing loss. So this is one scenario. And about the thyroid hormone, most of the cases, they may have even euthyroid goiter. So presence of goiter can be seen in 70 to 75% of cases. So in a newborn having a congenital hypothyroidism with a goiter, so always suspect Pendred syndrome as the underlying etiology. And as it is autosomal recessive, so family history, and especially with the history of consanguinity, this becomes very important. So
The
we
good thing
quickly,
is that most of the attendees have rightly pointed out for
okay,
Pendant
okay, so
syndrome
very,
and its
very, okay.
inheritance.
So the objective, the purpose of these talks has
Yes.
been served very rightly. So quickly moving on to the third question. So there is a 5-year-old girl who was previously well and presented in PICU with history of weight loss, loss of appetite, and sleeping difficulty. So on examination, she has a toxic look. She's not looking well. She has high temperature. She has fever. Her heart rate is on the high side. And if you can see blood pressure, again, she has hypertension, and she has resting tremors. Again, this is the catch here. She has warm peripheries, exophthalmos, and a grade 1 goiter, which is non-nodular and diffuse goiter. And the ECG shows left ventricular hypertrophy. And there is a significant family history of paternal grandfather taking treatment for hyperthyroidism. So there are many catch and cues in the history itself. So the question, what is the condition that you people would suspect in such a situation? What is the expected thyroid function result? And name the scale. How do you diagnose and how do you scale this condition? What are the specific antibodies which can be ordered in such a situation? And the drugs, how do you manage the medical management of this condition? So again, identifying the condition is very important. So we have certain clues in the history. So the first thing is whether the girl is showing features of hyper or hypofunctioning thyroid. So do we have any answers?
Yes.
Thyrotoxicosis, thyroid
There are
storm.
three answers which has taken rightly. That is,
Okay.
some has written thyroid storm, one is thyrotoxicosis, and the grave.
Hyper. Okay.
So probably all are right because you are thinking about thyrotoxicosis. So
Yeah.
hyperthyroidism condition.
Okay,
Please.
so you have hyperfunctioning thyroid, so you have all the features associated with sympathetic stimulation. So the condition, so talking about the condition, definitely as very rightly pointed out, it's a thyroid storm with hyperthyroidism, this which could be mostly because of underlying Graves' disease, which is untreated, or it could be, or if the treatment has been stopped for a while, or even in toxic multinodular goiter, you can have thyroid storm. So always be wary and be cautious of this condition in having any person who has hyperthyroidism. So definitely the biochemical parameters would be elevation of T4 and T3, and with as a result, suppression of TSH. So this is how the biochemical picture of a person with hyperthyroidism would look like. So how to identify? So you have a scale, like you have scale for different conditions. You have Birch-Watowski's point scale, which is most favored. Again, then you have Japanese Thyroid Association scale, but this is the most favored scale. So how does it measure the grade of severity? I'll come to it in a short while. Then as far as the corroborative evidence, the antibodies, again, because this has an underlying autoimmune etiology. So the TRAB antibodies, these are more sensitive for detecting hyperthyroidism, and the treatment would be suppression of the thyroid. So you have to get anti-thyroid drugs, which have to be started. And because the conditions, this all the hypertension, the tachycardia, the symptoms, the warm peripheries, and the child is having is because of excessive sympathetic stimulation. So you have to take care of that. The propranolol should always be started to take care of the acute symptoms. And for certain situation, even thyroid might be required. So this is the line of management of a child having thyroid storm. So talking about the scale, the diagnostic criteria for thyroid storm. So it looks at different parameters like based on the degree of temperature that the child has, the CNS symptoms, the GI symptoms, and the cardiovascular symptoms the child can have. And these CNS symptoms, if the child has CNS symptoms, that carries a very adverse outcome and with a bad prognosis. So you have to, based on the level of involvement of a particular system, you have to give points. And if the score is more than 45, it's highly suggestive of thyroid storm. So it is one of the very few emergencies which are seen in endocrine practice. So this is one condition. You should always start the treatment then and there itself. And if the score is less than 25, so the person is unlikely to have thyroid storm. Okay, so atrial fibrillation. So depending upon the severity of the symptoms, you have to grade and then decide about the management. And especially this is for prognostication purpose. So this was identified. So now we have a thyroid result, and you have answer keys like 5 conditions. So you have to match. So we have a condition, the first diagnosis where TSH levels are very high with the low T4 and T3 levels. So out of these 5 conditions, what could that be? So 5 options that we have are thyrotoxicosis, primary hypothyroidism, thyroglobulin binding globulin deficiency, TBG deficiency, thyroid hormone resistance, and secondary or central hypothyroidism. Okay, so you have to just grade. So in the second situation, we have TSH, which is normal. T4 levels is low, whereas free T4 levels, again, this was discussed in the talk. T4 levels are normal. So what could that condition be? So you can note that down or either type it in the chat box. In the third situation, we have TSH level, which is low, and all the 3 parameters are low. This is the third condition. In the fourth, we have high TSH and all the 3 parameters are high. So which among these 5 conditions can account for this biochemical abnormality? And in the fifth situation, we have TSH, which is low, whereas the total levels are high. So we have 5 conditions. So do we have any answers from anybody?
Yes, I have received. Dr. Naveen has rightly pointed out that TBG deficiency.
Okay.
Yes, perfect thyrotoxicosis. Yeah.
Well, come to the answers. This is a
Yes.
clear-cut case. So in the first situation, you can see the level of the hormones are low with the resultant rise in TSH. This is what you see in primary hypothyroidism. Then the TSH levels are normal. The total levels, again, that was discussed. Whereas the free, so that is one reason why free T4 levels are always favored over total, because total T4 level can be affected by TBG deficiency. So this is that condition. So you have everything low. So that could be because of the central hypothyroidism,
Yeah.
but always remember it is low TSH is not always the situation. In certain situations, you may have even that normal. So because the hormone levels T4 and free T4 and total T4 are low, so if the TSH, even it is normal, but not elevated, like inappropriately normal, that is not appropriate. Okay. So that is secondary or central hypothyroidism. So either it could be borderline elevated, low, or even normal. So this is central hypothyroidism. Then you have another condition where all the 3 parameters are high. So that calls for resistance. The enzyme, the hormone levels are high, but they are not able to act at the receptor. So the functional hypothyroidism, as a result, TSH gets secreted. So all the 3 parameters are high, which indicates thyroid hormone resistance. I think that is understandable and should be clear to all. And then we have a condition like in that case where the hormone levels are high and leading to suppression of TSH. So that is thyrotoxicosis. So I hope that is clear to all. If any confusion.
Just I want to add one thing, as Dr. Vanda ma'am has already pointed out, that the fourth condition, that is high TSH, total T4 high and free T4 high. So before putting thyroid hormone resistant, we have to check the compliance and we have to inquire about that popping up the drug on the very recent. So that may be a pointers toward that.
Exactly.
So
Always
yes,
think of common things first. So whenever you
yes,
have any deranged with no clinical manifestations, so always think about the compliance, especially in conditions which require treatment for a prolonged period of time. So always the type of drug and how they are taking, that is very important because that's a very common scenario. So compliance
yeah.
always is the priority here. Very rightly pointed out by Dr. Vijay. So we have another question. So this is a technetium 99 a scan which has been done. So we have situation A and B. So what does this picture show? And then the third part is what is the radiological scan of choice for thyroid dysharmogenesis? So what can you interpret from the first picture here on the left? क्या लग रहा है ये? This is? Okay. Do we have any answers, Dr. Vijay?
Yeah, one answer is there, that is lingual thyroid some has written.
For the first or the second, A or B? Abhishek, okay.
It is not clear actually that
Okay,
what is
okay.
the
I think we are
response.
running short of time, so I'll go to the
Yes, yes,
answer.
please,
So,
please go ahead.
yeah.
Yes.
So, okay, as you can see, you cannot localize the thyroid gland at the place. So, because there is no uptake of this contrast. So, this is thyroid agenesis, whereas perhaps Abhishek wanted to say about the second part. So, where
Yes.
this uptake is not at the proper site, at the lingual part. So, that is thyroid ectopia. So, this is evident. Then, for the question that radiological scan of choice for thyroid dysharmogenesis, where there is problem with the formation of the thyroid hormone. So this perchlorate discharge test is the best test. And I think there is a slide. So what actually this test does is you check, you give radio labeled iodine to the person and then wait for like 1 to 2 hours so that that can be taken up at the thyroid. Then you give perchlorate orally and after an hour you look how much thyroid has been taken and how much can be excreted. So routinely in a normal case, whenever you give radio label, there should not be any difference before perchlorate and after perchlorate, right? But if there is any organification defect problem at the level of formation of utilization of iodine, you can see say in simple terms, then there will be excess discharge. So this is how you utilize perchlorate discharge test to know about like organification defect that you can have in Pendred syndrome and in other conditions also. So this is what is the rationale behind this going for perchlorate discharge test. So any questions, any doubts about this test? So before and after, usually there should not be any difference. If the difference is more than 5, that is after giving perchlorate an hour after perchlorate, it's more than 5%. You calculate the index based on the formula, then that is taken as a positive. That is an abnormal result. Okay. So this is what is perchlorate discharge test. Uh, then moving on to the next question. So we have a 10 years old boy who presented with painless increasing size of both the testes. Height, as you can see, is less than the 3rd centile, and the height velocity has been below the 25th centile over the last year. And weight is again not that much affected. It's on the 75th centile, and the chronological age is 10 years and has a delay of bone age, which is falling at 7 years. Now the questions that are asked is name one condition where precocious puberty, again, this topic has been so nicely discussed, with short stature and delayed bone age is seen. So what is the condition? So I'm sure you'll always remember, just to reinforce the same thing, in normal cases of precocious puberty, you always have tall stature because there is puberty. So in a normal case or in central precocious puberty, you have a child who has features of precocity along with increase in height. But there are very low, very like limited conditions where, or you can say alarming conditions where you can have precocious puberty with short stature. So this is itself is a very important clue to arrive at a diagnosis. Investigations, once you know the diagnosis, so investigations, ordering investigations becomes easy. What is the cost of testicular enlargement? Because this condition has been discussed and you had a female child who had breast enlargement and menarche at an unusually early stage. So in males, so the same reason can lead to testicular enlargement, and how do you manage? So anybody taking up the question? one answer we have?
Yes, please go ahead, ma'am.
No answers. Okay. So I'll take the answers then. I'll quickly move to the answers. Okay, so as you must have gathered by now, so this is primary hypothyroidism with pseudo or discordant precocious puberty. So the clues again here were that the child had precocious puberty with short stature. So that was a case of primary hypothyroidism, and the investigations you will order TSH, free T4 levels, and also the hormone levels depending upon the age of the child. So why does a child had macroorganism? This is because of the same reason that caused onset of puberty in females. High TSH, now they have analogy to the high FSH receptors. So whenever in cases of primary hypothyroidism, and it happens mainly in the prolonged, untreated, undiagnosed hypothyroidism, so where there is high levels of TSH, so they have a thing like molecular mimicry, where they stimulate the FSH, they act on the FSH receptors because of the same alpha units, analogy to the FSH receptors. So that leads to testicular enlargement. So they may have presentation like this, and the treatment definitely is thyroid replacement. The dose, the time, everything would remain the same. So for all cases of hypothyroidism, whatever the reason might be, the treatment remains just a simple drug which has to be given empty stomach. And always emphasize on your families and patients that they have to, the compliance with the drug is very, very important. And this is a very simple thing to treat, and everything will fall into place provided they are taking the drug as prescribed and taking it daily. So compliance is often the issue, especially with these conditions. So you have to tell them and have to manage accordingly. Then this is the last question that I have. So this is about counseling. So we had a talk on congenital hypothyroidism. So there is a newborn baby on day 7 he fails a newborn screening test. The TSH is very high, 256 international units per ml. The baby has all the manifestation which were discussed. So this looks like a clear-cut case. So what are the important points apart from the compliance that I would say again? So regarding further management, how do you counsel the parents? Because at this time there are not many manifestations. So at times it becomes difficult for the parents to make them understand that a drug has to be given and has to be given for almost 2-3 years, or maybe even longer. Okay, so because counseling also is a very important part of your managing a child. So in most babies with congenital hypothyroidism, the thyroid gland may not reach its proper place in the neck during development. So you have to explain to them that there is some abnormality in the thyroid gland, and which is nobody's fault, not mother's or anybody's fault. This is something which had to happen. Or another thing is you have to start the treatment, and accordingly some may be transient and some may be permanent. That will depend upon the cause. So usually there is no family history, so parents are not ready to believe. And at some conditions what happens, mother had this hypothyroidism detected, so parents believe maybe perhaps it's because of that. So you have to tell them it's nobody's fault. So just treatment has to be started, and provided treatment has been started well in time and adequate dosage, so nothing will happen to the baby. He'll live absolutely normal life, and with no issues with any of the glands or any of the systemic organs. And they may be another relative. So that again, that depends upon the etiology. So the chances of having another baby, well, that depends upon the etiology. So genetic causes, definitely there is always chances that the second baby may have congenital hypothyroidism. So every baby, irrespective of any family history, should undergo a neonatal screening, as very rightly pointed by Raghupati sir in the beginning. So thyroid imaging is definitely recommended. Ultrasound is available at all the places. So ultrasound has to be done, and the treatment has to be started, especially within the first month. Like within the first 2-3 weeks, the treatment has to be started. Because the more you delay in starting the treatment, the more adverse cognitive outputs the outcomes the child may have. So thyroid scan, because if they are available, that's a very good situation. But if it's not available, so don't wait for thyroid scan and report of thyroid scan. Start the treatment. That can be done later. And treatment has to be started well in time, because delaying the treatment is not at all which is something which should always be avoided. And they have to take levothyroxine, again, how to take empty stomach, and they can be mixed. It can be mixed with the express breast milk in a spoon and can be fed to the baby. I think this is all It has to be taken, and especially the iron preparation and soy preparation, because they might interfere with the absorption of the thyroxine. So you should advise them that it should not be taken with these supplements, and at least 4 to 6 hours a gap should be between the two drugs. Okay, so this is what I have to say. And any questions? This is the last question. Yes, any questions, any doubts you have? We'll be happy to answer.
So thank you, Dr. Aisha, for a nice case scenarios and OSCEs. So now we have completed 2 case presentation and including congenital hypothyroidism and acquired and the OSCE part. Now moving to the last part of the session, that is what are the theory questions which has been asked in the examination. So I'm going to share that one. Yes. So whether my slides are visible?
Yes.
Yes, sir. Yes, slides are visible.
So Dr. Javinder, can I start?
You can start, sir. Make them in, sir, slide share mode. They are not slides. Slide share mode.
Slide share, I think I have done. No? Yeah. Yes. Yes, you can see.
Yeah, we can see your slides, but they are not in slides. But you
Not
can,
in slide share.
they are visible. You can
Okay,
proceed.
okay. So thyroid gland. So coming each and every portion has been asked because thyroid is a very important thing. So the questions has been asked in detail that write down the embryological development of thyroid gland and associated abnormalities during the developmental course. So pertaining to say thyroglossal cyst or something like that. And what is the so embryology is also important. Once you know the embryology, probably you are going to understand better for the clinical and pathological presentation of congenital hypothyroidism. Again, thyroid hormonogenesis and its derangement has been asked in the questions. And third, that is neonatal thyroid screening. There are now guidelines and that has been published and that has also been asked in the questions. And thyroid function test and its interpretation, which has been frequently asked in your postgraduate examination theory questions. Now coming to the hypothyroidism, congenital hypothyroidism diagnosis and management, it has been asked. I have scanned for about 10 years of the last papers and it has been asked about 5 times. So newborn with goiter, etiopathogenesis of congenital hypothyroidism has been asked. Differential diagnosis of preventable causes of mental retardation, that has been asked as a short question. Discuss in detail causes, clinical presentation and management of juvenile hypothyroidism, acquired hypothyroidism. Enumerate common causes of acquired hypothyroidism in a 13-year-old girl. Discuss clinical presentation, investigation in brief. And approach to goiter in an adolescent girl with euthyroid.
Dr.
So this is a
Jaiswal,
case scenario which has been asked.
Dr. Jaiswal, your slides are not moving.
I am sorry. Yes. So whether this is stuck?
Yes, sir. They are showing just first slide only.
Oh, sorry. So I'll reshare, I think. I'll reshare. Yes, now you can, it is visible and it is changing.
Yes, sir. Yes, sir.
Yes, so we have discussed the hypothyroidism, that is congenital hypothyroidism diagnosis and management, newborn with goiter, etiopathogenesis of congenital hypothyroidism, differential diagnosis of preventable causes of mental retardation, discuss in detail causes, clinical presentation and management of juvenile hypothyroidism, enumerate causes of acquired hypothyroidism in a 13-year-old girl, discuss clinical presentation, investigation briefly. Approach to goiter in adolescent girl with euthyroid. Now coming to the third part, that is thyroiditis. thyroid's term has been asked so many times. Clinical features and management of Hashimoto's thyroiditis and Graves' disease has often asked. So these were the questions what I have scanned, and I think
Yes.
that's it. So I hand over to Dr. Javinder for the next proceeding.
Yes, sir. Sir, now we
Yeah,
are
I'm stopping
at
here.
end of our session, and I thank you everyone for your participation. Especially thank to Professor Raghupati sir for sparing his valuable time, and Anna ma'am and Vanna ma'am for taking beautiful lectures and which were quite informative and learning for the postgraduate students. So now I hand over to Professor Raghupati sir for his last wisdom pearls. So sir always give his advice with 1-2 cases in every session. So I hand over to sir for his any learning messages.
Thank you very much for Dr. Jaiswal and Dr. Javinder Yadav, and also the speakers, Professor Anna Simon and Professor Vanna Jain, and also Aisha and all the participants, the case presenters. It was a very useful session, I think, but there will always be questions. And I just heard or saw one message from Dr. Yadav that this will be available on YouTube. Is that right?
Yes,
Yes,
sir.
sir.
It's available.
Yes,
And
it will be available.
so please feel free to ask questions, even on the WhatsApp group, and I'm sure we'll be able to answer them. And there are some comments I wanted to make, but we are already running very late. I don't want to take more time. Thank you once again. And all the postgraduates, please await the next session and the topic. Dr. Yadav and Dr. Jaiswal will announce that. Thank you very much. Good night to you.
Yes.
Thank you,
sir.
sir. Thank you.
Thank you, everyone. Good night, everyone.
Dr. Javinder, just we have to announce. So, in the next, after 3 months, we are going to present probably related growth. That is short teacher and other things we are going to do. And we will intimate you regarding the dates and other things very shortly. Thank you all. Thank you so much. So, Dr. Javinder, shall I close?
Yes, sir.
Yeah. Thank you so much. Thank you.
Thank you.